So if you go, the dose reduction, this is just table explaining that principle. So in case of hemoglobin increase more than 2 grams within 3 weeks, if you're starting luspatercept, reduce the dose by 1 dose level, as you see in the graph, from 1.25 to like 1 milligram, or from 1 milligram to 0.8 milligram. And should be discontinued, the patient really did not experience any reduction in their transfusion burden after 9 weeks of treatment at the maximum dose level, if there is no alternative explanation for response failure are found. So as we summarize, just beta thalassemia, as we mentioned, is a genetic disorder causing chronic anemia. The lifelong red cell transfusion plus iron chelation has been the standard of care for decades. Allogenic stem cell transplant and gene therapy are really potential cure therapy. The gene therapy usually has a kind of level of case serious now, and allogenic transplant is usually most offered for so small subset of patients, and all the cut ages for transplant usually in pediatric at pediatric age. So we found that luspatercept is one of the first and only erythroid maturation agent that has significant impact reduction in their transfusion burden in patients with thalassemia. So the primary endpoint, which is 33% reduction between week 13 and 24 weeks, achieved like in 21% versus 4.5% in placebo. And as I mentioned, the most frequently reported adverse events was kind of non-specific, like headache, bone pain, and arthralgia. And only 2.6% on luspatercept discontinued therapy due to adverse reaction. It's administered subcutaneous and every 3 weeks. And that's it. Thank you.
Thank you, Dr. Sultan, for this comprehensive coverage of the luspatercept management and trials. Now the floor is open for discussion. Dr. Muhammad.
So, Prof. Saad, Dr. Sultan, and Dr. Farah, can for questions? Prof. Saad. So there is another mic, please. Hello. Yes. So, any question? Yeah, Doctor.
Assalamu alaikum. Dr. Jeffrey from Riyadh. Thank you for both speakers for excellent presentations. I have one question for Dr. Sultan and one for Dr. Saad. For Dr. Sultan Al-Mutairi, I don't know whether you've mentioned or differentiated between transfusion dependent and non-transfusion dependent in terms of response, because these are very important distinct features, and the majority of our patients are really the transfusion dependent patients, and I wonder what is the response in those category. The other aspect you mentioned about the possibility of allogeneic stem cell transplant for the, actually in our population, it's not for a small subset of eligible patients, but they are actually in our population, there's a chance of 66% for any given family to have a fully matched donor. And I agree with you, it should be done early. And I will present our experience in thalassemia transplant over the years tomorrow. So you'd like to start first, or shall I ask Dr. Saad? My question for Dr. Saad, for the splenectomized patients in thalassemia, they are of course prone to develop thrombosis. Dr. Saad, do you put them on aspirin after splenectomy, especially those with high or thrombocytosis above 1 million in pediatric?
Start first. First question or?
السؤال الأول كان luspatercept transfusion dependent thalassemia. So, I mean, the BELIEVE trial was selecting patients who was already transfusion-dependent beta thalassemia, which showed the most benefit of reduction transfusions. So, I mean, either patient became transfusion independent or became like requiring like 4 units, became 1 unit. And this is the main study. I mean, the drug, I think, is under development or under studies looking into non-transfusion dependent beta thalassemia. If you are asking about if the drug would work in both groups, I think from theoretical principle that it would work both in both groups. But the data now is mainly over transfusion-dependent beta thalassemia. It's quite effective. Second question about allogenic transplant. Okay. So the main barrier that I notice about for transplant is usually now we are trying to push patients with sickle cell disease, which can have more morbidity than beta thalassemia. But I think the priority of our transplant centers for malignant hematology cases and even for sickle cell disease, I mean, during my experience, which is not long, about last like 3-4 years, none of patients really have a bone marrow transplant. I mean, I was looking about their data about transplant. Usually, if it's going to be done, usually at pediatric age, it's better. So I think probably pediatric hematologists can shine the light about transplant at that age. Okay.
Second question.
Yeah, actually, I have a question. Dr. Saad, she has.
Dr. Saad, yes. Can you repeat the question for Dr. Saad? You asked her a question. Dr. Abdullah.
Yes, Dr. Saad. Thank you very much, Dr. Saad. It's regarding the splenectomized patients, and you know, we know that they can develop thrombocytosis, you know, and they're prone to develop thrombosis. Do you put them on aspirin?
Like I found aspirin is useless to prevent thromboembolism, and he had a lot of risk factor like bleeding. So for our patient, younger patient, like after splenectomy, if they are children, because we divide our patient to children, teenager, and adult, like for children, usually with splenectomized, we put them on antibiotic and vaccinations. In spite of all this, the patient died with infections due to splenectomy. In adult, we have a major problem if they are married and have get pregnant. We lost any patient. I'm not putting any patient on aspirin, but the obstetrician, they love to put patient on aspirin because they thought aspirin, they do good job. And we lost patient with a bleeding during delivery, and the risk of abortion, it's very high. So for me, I don't put them on aspirin. Thank you. It's a very important questions, and there is ideas. Maybe Dr. Farouk?
Please, Dr. Shah, can you just comment on the same question, please?
Sure. So there are the pregnancy guidelines from the Royal College of Obstetricians and Physicians, the RCOG guidelines, which actually do recommend thromboprophylaxis during pregnancy in post-splenectomized transfusion-dependent beta thalassemia major patients, but also recommend risk assessment and thromboprophylaxis using a combination of aspirin and low molecular weight heparin in the NTDT patients as well. Those guidelines are actually being revised at the moment, and they're now going to come under the banner of the British Society of Haematology guidelines. I'm in the process of finishing off the reviews for those. So that's what we would recommend in the UK. Clearly, thrombosis risk in the post-splenectomized patients is very high in the first 6 weeks after surgery. My practice and the practice of all of my colleagues in the UK is to give thromboprophylaxis for 6 weeks post-operatively, because that's when you're going to see the biggest rise in the platelet count. And then for long term, if the platelet count is consistently raised, and you, in fact, Dr. Jaffrey said a very high platelet count of over 1,000, we would, in those patients, do a risk assessment and then recommend aspirin. In some of our patients, we actually recommend cytoreductive therapy as well if the platelet count is persistently too high. And we may at that point do JAK2 mutations and then introduce hydroxycarbamide as well. We do have a couple of patients in that situation. I hope that answers your question there.
Thank you.
Okay, I have a question for Dr. Shah. This is Dr. Ghazi Damanhouri. I'm from Jeddah. Actually, really, I enjoyed your lecture regarding the, this. You covered very well the new trend and new treatment in thalassemia. Actually, my question is that we still, until now, I mean, our traditional treatment for these patients is transfusions, iron chelation. Okay. And then some of them, of course, they can go for transplantation. In UK now, at the current time, what is the most patients with thalassemia in UK? I mean, what you can offer them in a way that as a routine or something is really available apart from this traditional treatment? Yeah.
Thank you so much for that question. And there are common misconceptions that the UK has got everything available. Unfortunately, the Zynteglo was not approved by, well, Bluebird Bio withdrew their application from NICE before approval or refusal was granted. So we don't have gene therapy available in the UK outside of the context of a clinical trial. 4 of my patients have actually been cured with the CRISPR-Cas9 gene therapy clinical trial, but that's the only way they've got access to it. Standard of care, which is what you do, which is blood transfusion and iron chelation, is really all that we have. Luspatercept is still not available in the UK. Again, the same problem in that it is licensed in Europe, but it has to go through NICE processes before it's approved. And Bristol Myers Squibb, which now manufacture luspatercept, haven't submitted an application to NICE because we assume that they want to present the beyond the non-transfusion dependent trial data with the BELIEVE clinical trial data so that they've got a more robust body of evidence to support that journey through the NICE process. So we're no different to you, unfortunately. In Saudi Arabia, it's exactly the same therapeutics that we've got.
Okay, so one last question.
Yeah, assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, all speakers. My question, Dr. Shah, regarding the thalidomide use in patients with thalassemia. So in this study, do you think that there is increased risk of thrombosis? This has been reported in other thalidomide-containing regimen and multiple myeloma, particularly in patients with thalassemia intermedia?
Totally. I think that the problem with I think thalidomide is a really exciting intervention to think about in thalassemia patients. I think the problem we have is that all the studies are really small. They're not multinational studies, and I do think that it would be very important for a very large multi-center international study to be done with a lot of patients to actually define that risk. In the clinical trials that I've presented, there is a small increase in the thrombosis risk, and I would be really cautious about using thalidomide with the previous of thrombosis, or with other risk factors for thrombosis, such as, the high platelet count patients, those sort of patients, the NTDT patients who are very prothrombotic anyway. There may be an argument for considering some form of thromboprophylaxis whilst they're on thalidomide. So I think we have to balance the evidence with the concerns about the risk. And I think that we'll get better quality evidence from a very large multi-center trial, which will help answer your question precisely, inshallah.
Dr. Muhammad, just I have questions for Dr. Sultan before we close. I just would like to know if you have any experience outside of this research for the luspatercept that you used it in your patients or you know about.
But the drug did not arrive yet, so we don't have any patients right now on the medications.
But actually, it is approved here in Saudi Arabia
Yes.
by Saudi FDA.
Yes.
And just we started recently our patients, a few patients, we have 5 patients to start on luspatercept as a compassionate use. We just started first dose and we are not sure. We will follow up and see how it will be the effect on these patients. We hope that it's because it's promising medication that it will be of benefit, but we know that the cost is something we need to discuss and to see how we can, because as Dr. Shah said, in UK, not yet, because not everything is available everywhere. It's difficult when the medication is very expensive as a start, but if it is good on the long run, maybe we can consider using it. Thank you. And I think by this we can conclude. Yes, Doctor.
So thank you very much for attending. So we'll have break until 10:25, 5 minutes, and we'll start the second session. Thank you very much.
Thank you so much, Doctor.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. We're going to start the second session in track 2. My name is Dr. Mohsen Al-Zahrani, and my co-moderator is Dr. Mohammed Bakar. He will join us shortly. We have 3 lectures with eminent speakers about sickle cell disease. We are going to start with the first lecture about future of hemoglobinopathy in Kingdom of Saudi Arabia, and it will be given by Dr. Hatun Izzat. Dr. Hatun Izzat is well known to everyone. She's a consultant of hematology and bone marrow transplant. She's as well the director of hematology program at the Ministry of Health and the head of the hematology division at the Virtual Medical Center in Riyadh. She worked as a consultant hematologist at John Hopkins Aramco Health Care Center. She had obtained a Master of Science in hemoglobinopathy from University College London in England, and currently is the director of the Provincial Adult Hemoglobinopathy Program of British Columbia and the director of the Provincial Home Hemosiderosis Iron Chelation Program in British Columbia, Canada. So, Dr. Hatun, welcome. You can start your lecture.
السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا. جمعة مباركة. Can you see my slides? Okay, good.
Yes.
Good morning, all, and thank you for the opportunity. I just want to thank the organizing committee from the society and the SSBMT for having the trust again in me and calling me back for further presentations. I wish to be with you physically, but it's one of the COVID challenges, so alhamdulillah. I'm going to talk to you today about not much of scientific content as much as it's a presentation to sit back together and think and brainstorm and opening door for further collaborations and to put our hands together to improve the care of those particular patients in Saudi Arabia. So this is a pottery line that got me stimulated really and got the aspiration back in 2018, 2019 when it was given to me by one of the famous hematologists, قصيدة الطب قبل الحب أحيانا الفحص ما قبل الزواج, medicine before love, the premarital screening program. And it gives you really the pillars when you think about it of approaching and managing those patients with hemoglobinopathy. It says ففحص وليدك, so newborn screening, واستشر, which is the counseling program, وتعلم, education and continuous training, وخذ hydra, take your hydroxyurea, وماء زلالا, and lots of plenty of water, وتطعم, and vaccine. And on this, we were hoping to build new avenues for blood disorders, to go and see new hope to sickle cell disease and blood avenues. Our journey started by visiting health affairs at the Ministry of Health, and our assessment was based on patient journeys all the way from emergency to admission to the lab to using every single facility in the hospital as well as an outpatient. And we tested the transition program as well between pediatric and adults. That was in 2019, and we conducted workshops as well. We've developed our vision, mission, and KPIs based on that. And we started off by sending a survey just to test the water and check on numbers at the Ministry of Health for those patients. And they told us then that there were around 65,000 patients with sickle cell disease that attend Ministry of Health Affairs, hospitals and institutions. So over the coming few minutes, I'll talk to you about the projects and the plans, but we do know the challenge in every system where resources are so limited. And if you want to introduce any new resource, you want to come with new budget. So we tried to approach it in a different way, where we move resources, utilize them further, and develop new resources from all the resources. And then this will make our name disseminate and will bring in collaborators, and I'll show you how this happened. So the TTs stand for our hopes to have the territorial management, which is kind now presented in the clusters, team assignment and team training, and this is what we're doing with our education program, and twinning between center of excellences and hopefully national and international collaboration. The CCCs is the New Hope Avenue that I told you about, where it is a comprehensive care center that has all the pillars that you use or you want to use for those patients. And we've developed the sickle cell registry that I'll show you more about to be the umbrella for those avenues or units. We have now consultancy clinic, and COVID really with all the negative impact, we took the positive out of it, and it facilitated our virtual care that I'll show you as well. And then eventually, hopefully, we will develop a research center with collaborators. So this is the strategy for our program, where we have registry research and empowerment, training, development, education and knowledge dissemination, prevention program, operation excellence, and collaboration. So the first one is the registry, and this is one of the biggest thing happening at the ministry now. There is a vision to develop diseases registries at MOH. Sickle cell disease and thalassemia registry is the biggest one, is the first to start back in 2019. And it is a continuous registry based on multiple phases. We're done with phase 1 and now entering phase 2, where we collected around 300 plus variables and data on patients from 25 MOH hospitals. 14 of them were electronic medical records and 11 were paper charts. We've developed a digital platform that is unique for those patients. And we are collecting 3 years retrospectively, and hopefully with physician and nurses' help, we move prospectively. Phase 2 is entering now, and we're adding 15 electronic medical records, and we're doing further expansion. The aim is not only research and collecting data, but it facilitates patient care, where physician could and healthcare provider enter the system and help them in finding a patient pathway, as well as it will help Center of Excellences that we're working on, and the economic evaluation of new products and its impact. These are some of the variables that we're collecting, and these are the involved areas in the projects for now, and we're expanding on it based on a hemophilia registry that we're adding to this registry. Alhamdulillah, although COVID was there, but it didn't slow us much. So we have currently nearly 23,000 patients in the registry. Most of them are hemoglobin SS. And I have lots of data that I could share. We're publishing, inshallah, based on it. But this is just a sneak peek to what we have. Those are the 5 commonest comorbidities in those 23,000 patients. The youngest patient we have in the registry is 1.5 months, and the oldest is 106. May Allah bless him and give him health. This is an overview of the marital status of those patients. And you could see that consanguinity makes up 50% of those parents. This is an overview of their school attendance and how the disease is affecting their school attendance, where it become irregular, as well as it is affecting their employment status. This is a very important piece of info because it shows us medication use, and we always talk about hydroxyurea as the magic bullet, and it is the key for treating this disease, or the cornerstone, but it shows here that we are still underutilizing hydroxyurea due to many reasons. One of them is not being available, at least sometimes at MOH, but compliance is another major factor that we have to work on it, as healthcare providers. The commonest iron chelator used is X-Jade, followed by Jade New, since now it's available at the ministry, followed by the 2 others. This shows you how many patients attends inpatient and the burden of admission that is followed by complications and ICU use, sometimes mortality, not only morbidity, as well as the health cost that could come with it. 84 of events were for pain crisis and across all ages. And the commonest chronic problem, especially in older people or adult, is chronic pain, as you see. This shows you what is the population that are coming with more than 5 VOC through emergency room. And again, we did this to analyze the cost of this disease. And this is our phase 2 in inclusion for the expansion on the registry, where we will have the virtual care management capabilities merged into the registry. We're working on mobile apps as well as a patient portal called the Inherited Coagulopathy and Hemoglobinopathy Electronic Portal, where the patient actually could report their pain, bleeds, some were including hemophilia and its severity. They could send pictures to their healthcare providers, their medication use, their factor use, transfusion, as well as they're going to be able to refill their medications as well through the application. The second pillar that we've been using and working on it actively actually last year, and thanks to the virtual facilities, because it allowed lots of training to be moved on. We have several training programs, and I'm just going to talk about hemoglobinopathy here. So the SHIFT ARISE program had started last year. We have the clinical practice for cognitive behavioral therapy in sickle cell. We have the sickle cell emergency department training, and we have others for hemophilia and other blood disorders. So I'll give you some brief. The SHIFT ARISE program is divided into 2 phases. Phase 1, we contract with the ARISE, the African Research Institute, led by Dr. Baba Onusa, as well as UCL, to train hematologists and nurses. We have started the virtual training, and we're hoping for preceptorship once the COVID-19 is settling down. And then the second part to the SHIFT ARISE project is the GP counseling. And this was based on a book that we've published in end of November that talks about hemoglobinopathy and the counseling, in particular, the premarital screening. We've started the first session in Riyadh, and we're planning to train 350 general practitioner, or what they're called أطباء المشورة at MOH, and to allow them to train other people. The second one is cognitive behavioral therapy for sickle cell. We've signed a contract with Big Institute. Big Institute is the biggest institute worldwide to administer cognitive behavioral therapy training for different diseases. And the plan is to do all virtual except Big, and as well as Professor Kofi Ani will be in Saudi for CBT and sickle cell. The Big Institute will be teaching us about CBT and chronic pain, anxiety and depression. And this program is starting, inshallah, in a couple of months. The ED, emergency department training, we've finished the virtual educational part, which was 5 sessions to 5 areas in the kingdom, where we did virtual training for nurses and physicians in the emergency room. And next month, we're starting the physical training. We're going down to emergency sites. We have the pre-printed orders for managing pain approved and available on the Ministry website. And we're introducing the idea of a sickle cell wallet card project with this program. Education and knowledge, we've been working over the past couple of years on publication of several protocols. These are the ones available on the ministry website, and these are very active. We're almost done from the hemophilia and thalassemia, and the sickle cell will be hopefully by June. These are national protocols that will be available for all hematologists in the country. Prevention programs, several ones. The biggest one is the virtual medical center, and then we'll talk about screening program. So the virtual medical center is a physical center available at Riyadh Digital City with the Ministry of Health on the 3rd floor. It has several subspecialties and several unique actually services. The hematology service or the sickle cell service was the first to start back in May 2021, where we have a physician at the BMC refer the patient, but the patient is available at the spoke hospital with their patients as well to facilitate care, but to teach as well HCP at peripheral hospitals about these unique diseases and have the proper case assessment, health maintenance, short-term and long-term management, as well as empowering patients to be part of their care. I have a video here, but skip just given the time, but it shows you about how to refer those patients, and I'm very happy to have some communication afterwards if you want to know more about it. But basically, we're applying standards of care as well as the protocols that we talk about. We have two physicians managing the clinic. One is from pediatrics and one from adult, but I'll show you some of the innovation steps that we've taken until the soft launching was June 1st. We started our clinic back then. Actually, the clinic started May 31st, and we did the soft launching. Then it started as sickle cell disease, thalassemia, and then we've included hemophilia and rare bleeding disorder. And then the actual launch happened in August last year by His Excellency the Minister and Prince from SDC. These are the clinics, the way it started with the inherited blood disorder, and then we expanded to benign hematology. So the clinic currently covers all benign hematology. We've started a thrombosis clinic, and we just started with HESA, a pain and addiction clinic. And we are in the plan of starting now a PGD clinic, as well as stem cell transplant for sickle cell, that I'll tell you about those projects. The screening program, so this is an overall vision from us that we're working on internally and hopefully nationally. So the newborn screening, we've been working really relentlessly on it for the past 2 years. We've got the approval, and actually it started last month at Wiqaya, or the national lab. The new screening program is an ongoing program. However, it covers 16 diseases with inborn error and rare genetic disorders, and we've managed, alhamdulillah, to add sickle cell and beta thalassemia to it. So if negative, results will go to Sahha, and the baby would be issued a certificate. If positive, we will be helping to refer those patients to the nearest hematologist or inherited blood disorder for confirmation of testing and then clinical care. So this is an official one. It's approved and it has its own budget. One of the trials or the pilots we're doing is school testing, and we're starting with HESA, where we're going down to schools, testing them, and I'll show you the way. And the hope is just to have some more, not only knowing their disease, but more education and knowledge about the disease at this age. The premarital screening is an ongoing old program, started in Saudi in 2004, but we're adding a few things to it. So this is the current program. If positive, the marriage is delayed for one month, and they undergo several videos, educational session, hoping to cancel the marriage. If not, they will be counseled again and then referred to inherited blood disorder. But we're trying to work on the prenatal and antenatal screening. So why newborn screening is helpful in hemoglobinopathies? It is helpful from all aspects. And the easiest one to say is early recognition of those babies and early management to prevent outcome, extend life, and prevent morbidity and mortality, and to empower caregivers to know about this and decide about their future kids later on. So the plan right now is to document the screening, to confirm it through referring the baby to an inherited blood disease, but at the same time to give educational material and to meet with parents to let them know. A physician will start penicillin prophylaxis, will do the appropriate teaching and referral to a comprehensive care center, as well as vaccination. This is just a scheme that we put for the reporting according to results. I wouldn't really go into details, but depending on what is seen on the HPLC for baby, and this is the method we're using is HPLC, as well as we're doing GC6PD testing for all newborns. The school screening program that we're piloting is through a POC, or a point of care diagnostic. We have few machines, and we will be going to schools starting in April, inshallah, to test students and give them the knowledge about the disease. And if anyone is discovered to be diseased, the plan is to be referred, but at the same time, they could at least go through the normal process. The premarital screening is a program that started 2004 in the Kingdom, but had expanded to include 172 Ministry of Health clinics and 37 private clinics. Till date, there's near to 5 million people that they were screened for their premarital status. And these are the updated numbers. So the carrier status for sickle cell is 4.28, and the sickle cell disease is 0.3%. And these are the numbers for the thalassemia. So if you compare it with the previously, actually the numbers had increased. Maybe one of the factors is the expansion in the testing too. So what are we doing in the premarital screening? We start initially from different corner, but it wasn't really successful. But this is what we're doing. We've published the book and we're educating the GP on how to counsel people for premarital. So we're doing 350 GPs, and we started the first session in Riyadh. And then we're adding the PGD, or the pre-implantation diagnostic. This is a new project that I'll tell you briefly about. It's called مشروع غراس الوطني. As well as we're adding NGS, new generation sequencing. We have collaboration with BGI, and we will come up with certain criteria to test certain partners for with NGS for their hemoglobinopathy disorder. Operational excellence, we did several things. The NHCC is a well-known center at Riyadh Digital City. We managed to add a dashboard for hematology to monitor above 100 medications, and we come up with weekly tickets as well as solution. We have our weekly GWalk to monitor those screens and be in touch with the supply chain. We have different level of actions there to keep things moving and flowing. Just in regards to medication, as was mentioned in the previous discussion, the crizanlizumab, which is the new monoclonal antibody for sickle cell, as well as the luspatercept, are two medications that got approved by the Saudi FDA, and we have actually a committee to approve those medication on a compassionate access. We do have several patients at Ministry of Health that have been started on both medications. At a personal level, I've started both on several patients at Johns Hopkins Aramco Hospital as well. We've developed KPI, the commonest one that I think did some difference and made few people to make more attention is the door to painkiller KPI, where it's limited by 30 minutes. And this is a weekly KPI that gets distributed through the KPI group for institutes to come up with solutions and shed some light on those patients. The other one is a monthly KPI where we monitor services within hospitals that are provided for those unique patient population. And then we have the project for comprehensive care center. So the first center is starting in Al Hassa at King Faisal Hospital. We've already have the design, and we're working on having a one complete floor divided into 3/3. 1/3 is an emergency for milder to moderate form of VOC. It is a center that is across the street from the main hospital, so it facilitates transfer of patients that would need admission. It works 24 hours, so could keep patient up to 24 hours and then decide for admission or not. The middle part will be the clinics, where we have downstairs a multidisciplinary team from different specialties, and upstairs the clinic will include the hematology as well as psychologist and social worker. And then the third part is the transfusion bay, where it facilitates for healthcare providers who are doing the clinic to go to the emergency room, see the patient, and move to the more stable patient to assess them during their transfusion, to allow the healthcare maintenance for these patients. So it is a project that got started and inshallah will be active pretty soon.
1 minute, Doctora.
Yes, sure. I'm almost done. Collaboration, there are two things, many things happening, but two things that we're super excited about it. مشروع غراس الوطني is, we just formed the committee. It will be based on selected criteria for people who have an affected child and wish to have a healthy child to go through PGD. And we'll facilitate this through the virtual clinic. And the other one is just, we had recent discussion with our dear colleague, Dr. Mohsin Zahrani, and a bigger discussion at the ministry level and National Guard is to start collaboration for a program for hematopoietic stem cell transplant for sickle cell disease. I think with this, I could end my talk, but innovation is the sky and the sky is the limit. So keep on thinking. Approach us, please. And if anyone wants to collaborate or do something for those patients, we are really kindly open and appreciating that. Thank you so much and have a wonderful day.
Thank you, Dr. Hatwan. Excellent presentation, and we'll appreciate the work and efforts at the level of Ministry of Health in different directions. And hopefully this will be reflected to improved patient care and quality of care to our patients. We are going to have the discussion at the end of the session. Do you want to do it at the end of the session, or you want to get the questions now? At the end of the session, okay. So now we'll go to the second speaker, and he will be presented by my colleague, Dr. Mohammed Bakkar.
Thank you, Dr. Mohsen. Our next speaker is Prof. Shakir Musa. He is a professor of pharmacology at Albany College Pharmacy and executive chair of PRA at Albany, New York. Dr. Musa is a founder of Pharmaceutical Research Institute in 2002 and the founder of spin-off pharmaceutical and biotechnology companies. He held a senior principal research scientist and research fellow at DuPont for 2 decades. He held academic appointment as adjunct professor at Department of Medicine, Sol-Sherry Thrombosis Research Center at Temple University and the State of University of New York. Dr. Musa his work is reported more than 1,000 peer-reviewed publication and hold over 4,000 U.S. patent and international patent. He is involved in the discovery of novel pharmaceutical aspect of heparin and non-anticoagulant heparin derivative. Dr. Musa is going to present a topic about new heparin formulation as a potential treatment for sickle cell disease.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. It's a pleasure to be here among friends and colleagues, brothers and sisters. And may Allah subhanahu wa ta'ala.
The voice is working.
Can you hear me?
Yeah, it's not working. So it's not working, the mic.
Can you hear me? Can you hear me?
Yes.
Okay, good.
That's good.
Assalamu alaikum.
Alaikum assalam.
Heparin in sickle cell started here actually in Jeddah at King Abdulaziz University Medical Center in collaboration with a large number of collaborators headed by Professor Qari. This was reported with one of the low molecular weight heparin in 2007 in thrombosis hemostasis. One of the landmark study, when you go to the ASH, that will be the landmark studies. And since then, we try to ask ourselves a lot of questions. Can we improve the low molecular weight heparin to make it a safer and more effective in the management of sickle cell and its complication, not only the sickle cell manifestation, but the complication in sickle cell. So what we did an engineering of low molecular weight heparin to make it non-anticoagulant, but still antithrombotics. And I'm going to explain mechanically how did we do that. And then we engineered an anti-sickling, an aldehyde function similar to GBT compound, which is FDA approved. Of course, this molecule, if you sulfate the sugar in the low molecular weight heparin, you can enhance the affinity of binding to the endothelium. So you can attain an improved anti-selectin activities, anti-adhesive activity, which mimic the antibody by Novartis, which is being FDA approved for sickle cell disease management. So I'm just going to explain to you. And then we get rid of the anticoagulant, systemic anticoagulant, so there is no bleeding side effect, but still sustain an antithrombotic activity via the binding to the endothelium and the release of local natural antithrombotic, which is tissue factor pathway inhibitor that blocks the tissue factor 7A complexation. And if you block the tissue factor 7A upstream, in a way, you can turn off the 10A, factor 10A and factor 2A generation. And it's much safer because you do it at the local vascular endothelium. Furthermore, in a sulfation of the sugar, enhance nitric oxide release from the endothelium. So you can induce vasorelaxation. One of the sickle cell manifestation is vasospasm, a deficit in nitric oxide. So we can overcome that. And then you have a major effect on the inflammatory cells, the monocyte, the macrophage, the lymphocyte. So you can, via NF-kappa B, you can, this molecule will turn off the pro-inflammatory stimuli. So I'm going to show you the data and the evidence. This was just presented at the American Society of Hematology in an oral session. And I'm just going to give you the highlight. What we did in the formulation to, low molecular weight heparin, and I'm just giving you a run through the whole scenario of my talk here. So summarizing a lot of data that I will show you. What we did also, we did a nano formulation because low molecular weight heparin have to be given subcutaneously once a day, or twice a day. And we need to, so what we did overcome the pharmacokinetics, the short half-life in the blood, by sustaining a high level, circulating a high level of the sulfated non-anticoagulant low molecular weight heparin. We call it SSH. And the formulated product is called VVB, which is one of my spin-off companies, Vascular Vision Pharmaceutical 728. We are currently working on IND to get it ready, funded by the NIH. They funded us about $3 million to finish the IND. You have to have an IND to start phase 1 in sickle cell patient on healthy volunteers. Once we finish phase 1, then we can actually come to the kingdom here to do our phase 2 clinical trial. So this is the sequence of events. The nano formulation, and I'm just going to give you, what did this inspired from? This was inspired from our work on camel. And what we found out, the urine from the camel secretes a lot of heparin byproduct. Among these heparin byproduct was this sulfated non-anticoagulant heparin. And in the milk of the camel, there is lactoferrin. If you should know, as a hematologist, that heparin and low molecular weight heparin and a polyanionic compound, they have a negative charge. You can never get it to be an orally bioavailable because it will not absorb negatively charged molecules, will not cross the GI. So what we did, we used lactoferrin, which is derived from the camel milk, and they made a complex, nano complex. Lactoferrin is a polycation, positively charged. So they form a complex. We stabilize the complex by actually simple mixing of the two together, and that form a nano-formulated product that's highly orally bioavailable. So we can also give it subcutaneously to achieve a long residence time in the blood, in the circulation, to get the sustained anti-sickling effect. So clearly, if you go back to Prophet Muhammad sallallahu alaihi wasallam, from his hadith, mixing the camel urine and the camel milk, you can get the same product by simple mixing the two together, because you have lactoferrin in the milk, you have the sulfated non-anticoagulant heparin in the urine, and that will form. But we synthetically, we published this in Science in 2011, we can actually,
do you want to move the slides?
No, I'm just giving them around. I'm going to be very quick to give a chance to the last speaker so we can get ready for Jum'ah prayer, inshallah. So I'm just, let me go through the slides. And the slides here are general background, which all of you are really familiar with, the complex pathophysiology of sickle cell disease. You have, the red blood cell is at the center, sickled red blood cell. This is where the problem starts. You have the sickling, the adhesion of abnormal sickled red blood cell to the endothelium. So you can injure the endothelium. You can activate the sickled red blood cell can interact with platelet. So you can promote thromboembolic events. The sickled red blood cell can interact with monocytes because there is a cell-to-cell adhesion via cell adhesion molecules. One of the cell adhesion molecules that is very important here is the P-selectin, or the selectins in general. And that's why Novartis developed an antibody against selectin. This molecule that I'm going to speak to you about is one of the best anti-selectin, have very high affinity for to block selectin binding, mediated binding. Then you have here, let me see, oops. you have the hemolysis, because there is an injury and there is a lot of the sickled blood cell is very fragile, and the cell-to-cell adhesion induce breakdown of the plasma membrane, and then you destroy the endothelium as well. And then once you have a free hemoglobin, you can inactivate nitric oxide, and that will lead to a lot of complications. So there is a lot of it's a vicious cycle in sickle cell disease. And what I will show you here, that this is the summary of the multiple biological processes contribute to vasculopathy, red blood sickling, inflammation, cell adhesion, thrombosis, deficiency of nitric oxide, pro-angiogenic activity. All of these manifestations in the pathophysiology of sickling can be attenuated very effectively with the molecule that has multimodal effect at all of these levels. And this is actually to summarize again, the different, what can you do in a way to attack or to tackle, to manage to have an improved sickle cell disease management. You need an anti-sickling. You need an anti-sickling activities in a way, to actually maintain the hemoglobin level, and to avoid avoid also the hemolysis. You need to protect the endothelium. The endothelium is at the center of all of this. Mitigate vascular occlusion, because this will lead to inhibition of and this is where the SNH will result in antithrombotic activity at the vascular endothelium level. Then you have an anti-angiogenesis. There is an inhibition. You need to inhibit abnormal angiogenesis. there is a lot of leaky vessels. You need to shut down these leaky vessels. You need to mitigate nitric oxide deficiency, relax the endothelium, the anti-adhesive, all of these characteristics and that can be improved with this sulfated non-anticoagulant, and in particular, to make it more practical, is the nano-formulated version of this sulfated non-anticoagulant heparin. And I just mentioned this in the beginning, the randomized double-blind studies that was done here in the kingdom, reported in thrombosis hemostasis in 2007, where tinzabirin, one of the low molecular weight heparin, shortened the duration of both vaso-occlusive crisis and hospitalization by about 40%, and resulted in significant faster reduction of pain. However, there was a lot of limitation. The limitation of low molecular weight heparin was bleeding side effects and the dose limitation. You can't dose it high enough to achieve, there is no anti-sickling in low molecular weight heparin. Low molecular weight heparin has an alcohol function, not an aldehyde function. And that's what we engineered, converted tinzabirin into a non-anticoagulant, that actually, that material, as I mentioned before, exists in camel urine. This is, some of the pharmacology of low molecular weight heparin. And in particular, you have the anticoagulant activities, which is inhibiting factor 10A and factor 2A via the binding to antithrombin. So what we did here, as I said, we iodate oxidation. We were able to open the ring in the pentasaccharide, and that has basically eliminated the anticoagulant and the binding to antithrombin. So we eliminated the inhibition of factor 10A and 2A. And that resulted also in generation of an aldehyde function. So converted all of the alcohol function into an aldehyde function. So this becomes similar to GBT, the GBT compound, GBT404, which have only anti-sickling effect. So we were able to add an anti-sickling effect to the molecule. So this is actually how the molecule structurally looks like. So you converted in the red here, the alcohol to an aldehyde function. That aldehyde function bind to the abnormal, the amino acids that's being mutated, and that basically stop polymerization, abnormal red cell, abnormal hemoglobin polymerization. And this is the anticoagulant activities. If you look at the anticoagulant relative to of this SNH in the brown here, relative to heparin or low molecular weight heparin, you can see it does not have an the ABTT effect, no effect on ABTT, no effect by different assays, by Trini clot assay or hemocell assay. Oh, I'm sorry. Yeah, and if you look at the anti-10A activities, there is almost no anti-10 activity in the brown here relative to low molecular weight heparin or heparin, no anti-2A activity, very flat. So there is no systemic anticoagulation. And as compared to the standard of care or FDA approved the product, you have hydroxyurea, you have the NDRA, GBT440, the monoclonal antibody, the anti-selectants, the phosphodiesterase inhibitor, suvabirin, which has actually failed in clinical trial, and we know exactly why it failed. And then gene therapy, which is still some time to go. And so that's why we feel that SNH could be an effective modality via its multimodal mechanism and safety for sickle cell disease management. Not only sickle cell disease management, but the complication of sickle cell. And additionally, recently we did a lot of study in immunology. We found this molecule and actually low molecular weight heparin, if it's dosed high enough, you can get an immune modulation. Especially in managing sickle cell disease patient with the COVID, they really have a weak immune system. If you can boost their immune system, that will actually help them to be protected against those different variants of the coronavirus. So this has an immune modulation effect, and that's known about heparin in the literature. This is the modeling for the SNH binding to hemoglobin S. So you can actually modify hemoglobin S, increase hemoglobin F in a way similar to GBT, even better than GBT. And actually, in a way also, this is a feature that exists in hydroxyurea. So in a way, we did extensive studies in collaboration with the CHUB, the Children's Hospital in Philadelphia, in a way, because they have a strong expertise in developing. Actually, they were behind the development of GBT, and they compared this molecule to GBT 440, and the data very clearly showed this is in vitro studies and in vivo studies in a town models, which is a sickle cell disease models, not in human, but also we took XV samples from sickle cell subject. We did this here in the kingdom at King Abdulaziz University with Professor Qari. We did it also in a CHUB in Philadelphia. And the results showed very clearly that we can actually, this is the SNH, and you look at the sickling in a way in the control here. Sickling here is very clear, in a way crescent shape, sickle cells. You can really, in a way, prevent sickling. Not only that, but we found out that we can reverse sickling. After you initiate sickling under hypoxic conditions, if you add the molecule afterward, you can start to reverse sickling, so you can increase hemoglobin F, as you see in the bottom here, and you can modify hemoglobin S. And we have done, as I said, extensive studies at different doses, and you get the same results in a dose-dependent manner if you compare it to the GBT compound in vitro. In terms of the sickling, you can see that this is the GBT compound here, and this is the inhibition of percentage inhibition of sickling with the SNH at different doses. So you can achieve at equivalent, and this is not the only mechanism. This is one of the many mechanisms that is anti-sickling is one of the multi-mechanisms. And oxygen saturation and increased oxygen affinity of the red blood cell is exactly comparable to the GBT. And as you see it here, 1 millimolar of GBT and 2 millimolar of this compound can achieve the similar increase in oxygen affinity with regard to anti-sickling. In the town model, if we look at survival, the control groups, the mortality, if you subject those sickle cell animal to hypoxic condition, severe hypoxic condition, you can have a very high mortality, as you can see from that line here. But if you have SNH treated groups, you can actually improve mortality, and this is non-formulated product that has a short half-life. And again, the anti-sickling in vivo relative to hydroxy, methylfural. So you can have, this is, a hydroxy methylfural. You can get at 2 hours, almost about, 50% anti-sickling effect at a very reasonable doses. So in order really to improve the circulating half-life, nanoformulation was the answer to that. And that has enabled us to formulate this for subcutaneous use and for oral formulation. And using lactoferrin or chitosan, another polycation. But I really like very much the camel lactoferrin because it's a very heat stable, has a very good feature. The circulating half-life was much more extended. All of this work is actually patented. We have about 10 US patents issued with this product. And if you look at the anti-sickling at 1/3 of the dose with the nanoformulated nanoparticle here, 33 milligram, this molecule also you can dose it at a very high dose without any red flag, without any bleeding side effects. This is actually one of the advantages. You can now capture the real benefit that's hidden within heparin. So if you look at this is 6 hours, you can get a sustained anti-sickling effect for extended period of time relative to the non-formulated, you can get this maximum effect and it wash out very quickly. This is the anti-selectin. Actually, this is one of the most potent anti-selectin because of the sulfation. If you look at the green light in terms of inhibition of selectin adhesion, this is what the SNH is relative to even the whole molecule of heparin, the black. This has a higher affinity than heparin itself as an anti-selectin. And this is published in Hematologica late last year. If you want to read the whole article, I think the reference might come very soon, or you just search under my name. So you can actually decrease pro-inflammatory cytokines, chemokines, and you can increase the natural anti-inflammatory molecule like IL-10. Very, very effective molecule in terms of modulation of inflammation. Furthermore, which we did not share outside yet, this has an immune modulatory effect, this molecule. So again, if we look at this VVB728, which is a nanoformulated, it has all of the feature of all of the molecule that exist combined together. So either you choose VVB728 or you can combine hydroxyurea with the GBT, with the Novartis antibody, with the glutamate. If you combine them all together, I don't think you would even come close to one single molecule that can be given subcutaneously, self-administered, or for long-term use on oral administration. And this is to basically summarize some of the aspects. The other thing, this molecule has a very effective local vascular antithrombotic effect via tissue factor pathway inhibitor without affecting hemostasis. It does upregulate nitric oxide from the vascular endothelium. This is the TFPI, TFPI1 and TFPI2 highly increased in the circulation, and that basically shut down the initiation of the cascade upstream at the tissue factor 7A. And that is the safest way, and it's at the local level in the vascular endothelium. And it does have an antithrombotic activities, especially this molecule binding to release TFPI, increase the affinity of TFPI. So you can actually, this is using the thromboelastography. This is far better you can actually get the same benefit like low molecular weight heparin and enoxaparin in terms of the strength, the clot strength, and the delay in the clot initiation without any side effect. So in summary, this is a modified low molecular weight heparin, successfully engineered to be devoid of anticoagulant properties, and it acquires potent direct anti-sickling effect. Does not exist. This does not exist in low molecular weight heparin. In vitro, it modifies the sickled hemoglobin, increase oxygen affinity, and inhibit sickling of the SSRBC under hypoxia. It reduced circulating level circulating red blood cell in town models and in human ex vivo. And also, there is a lot of studies planned now. We are just finishing the IND to get it ready to enter phase 1 clinical trial in the US, and this is sponsored by the National Institute of Health. They just funded this $3 million to finish the IND, and we will continue to work with them to get phase 1 done. And once we get phase 1, we can come to the kingdom here. And this can be subcutaneously administered and orally administered. And I want to I thank my institute here, the Pharmaceutical Research Institute, and the company that is actually spin-off company. I'm the founder of this company to tackle sickle cell disease, and Dr. Abdul Malik from the Children's Hospital, and the international collaborator, Dr. Kari, who started the concept with us earlier with the low molecular weight heparin, which we managed to make a major improvement over low molecular weight heparin, and the funding agency, especially the National Institute of Health. Thanks so much for your attention.
Prof, can you sit here? Yeah. Thank you, Prof. Musa, for this novel approach and novel idea to help sickle cell patient. We will leave the question at the end of the session.
So the last presentation will be given by Dr. Sultan Al-Mutairi, and he was introduced in the first session. And his talk is going to be about new advances in sickle cell disease. Dr. Sultan.
استنى محمد. ننتظر بس يعرضون المحاضرة عشان ما عندهم مشكلة شكلها. محاضرة غير معروضة بس. اوكي. السلام عليكم مرة ثانية. My talk just will be focusing about update in management mainly. So we'll go quickly over the current standing, where we stand as medical management of sickle cell disease, why we need the newer therapies, how this newer therapies act in the context of pathophysiology, and we'll go over some of the phase 2, phase 3 trials in sickle cell disease. We'll just skip this slide. So there are two mechanisms usually in sickle cell disease, and this is all the therapies trying to target, which is the vaso-occlusion phenomenon and the chronic hemolysis. So until recently, we're like having 3 lines of therapies, which is hydroxyurea approved in 1995 in adults, and blood transfusion. So patient having a complication will go to transfusion or from the get-go, and bone marrow transplant as the only curative therapy. So the first thing that we needed newer therapies, that since approval hydroxyurea, not all patients really respond to hydroxyurea. So around 20% of patients does not respond, and this is kind of was like interesting study where they try to do direct observed therapy for patients to take hydroxyurea to avoid non-compliance barrier. The second thing, the survival in sickle cell disease. So this is between data collected around 88 to around 1988, where the median survival for patient males around 42 and the median survival for females around 48 years old. So since introduction of hydroxyurea and comprehensive care, this numbers really got better, like age up to 50s, mid 50s, and probably from UK come like age of 60s there. The other thing is the morbidity of the disease. So it's almost every organ in the body might be affected by sickle cell disease. And these kind of morbidities that can be affecting their quality of life. And as you see in this table. Other things that we need newer therapies is the cost of admission to hospitals. So this data from Florida, as you see, I just wanted to focus on the blue color. The blue color is a reflection of the admission due to pain crisis. And as you see in patient with sickle cell disease, the vaso-occlusive crisis was the main reason for admission of hospital and the main impact of the cost on the economic system. The quality of life, and this is kind of local studies where like estimated that 6 out of 10 patients with sickle cell disease will have at least 3 ED visits within 6-month period. And these patients are usually students, or they have jobs that usually interrupted by the disease presentations. So the newer therapies were trying to target different aspects of sickle cell disease. So there are multiple mechanisms that involving in the pathophysiology of sickle cell disease. Whether drugs that are trying to look about anti-adhesion, as we know at the level of post-capillary venules, there is upregulation of adhesion molecules, like there is a B-selectin, E-selectin group, or VCAM. So drug targeting that would be working fine. The second thing is antioxidant, because they noticed like a lot of free oxygen radicals that downregulate the nitric oxide and also present like a stress on red cells, leading to initiation of vaso-occlusion. Antiplatelets being tried because we noticed in vitro studies that the platelets in inactivated states. Anti-sickling, trying to block the hemoglobin polymerization steps, and we'll talk about one of these drugs later. Hemoglobin F induction. So they noticed that patients with high hemoglobin F, hereditary persistent fetal hemoglobin, they do better. So drugs targeting hemoglobin F also were tried to increase these numbers. And anticoagulants. There is a lot of thrombin generation observed in patients with sickle cell disease, relatively lower levels of protein S and C in these patients. And this is just a sample of, there's a lot of other drugs in each category that had been tried. So we'll talk first about the FDA-approved medications. So Foxilitor, it is an oral medication that's the first of kind after hydroxyurea that try to target the mechanism of the disease. So it binds to the alpha chain of hemoglobin S, trying to interrupt hemoglobin S polymerization by increased affinity to oxygen. And this was kind of HOPE trial, the landmark papers. The trial was including age of 12 and above. They allowed patients with hydroxyurea to be included in the study. And the primary endpoint was different. They were looking about increase in hemoglobin level by more than 1 gram. Other secondary endpoints was the annualized incidence of vaso-occlusive crisis. They have two doses, 1500 milligram and 1900 milligram, and the 1500 milligram is really the approved dose. The baseline characteristics were kind of similar between Foxilitor and placebo. And as you see, like the 1500 milligram resulted in improvement in hemoglobin maintained through week 72 in these patients and compared to placebo. And the proportion of patients really achieving hemoglobin increase more than 1 gram or 2 gram or 3 gram. As you see, more than 1 gram, like 88.9%. More than 2 gram, like 60, close to 60%, and some patients really more than 3 gram per deciliters. And the vaso-occlusive annualized incidence rates was not like one, it wasn't one of the primary endpoints that study looking for, but there is, as you see, there is favoring reduction of pain crisis eventually. So they looked at also the hemolytic markers, and there is also reduction in hemolysis. And they looked at reticulocytes, LDH, and indirect bilirubin by interrupting the hemoglobin S polymerization at the earlier stage. The adverse effects, I mean, the main side effects that was observed, like headache and diarrhea, and really did not lead to discontinuation of therapy. This is also another paper. They look into real-world effectiveness of Foxilitor for treating sickle cell disease in the US. slide. So around, they looked about 37 patients who have really one hemoglobin tested within 30 days before and at least one test after voxelotor initiation. And as you see, it's still the results kind of reproducible with 54% of patients have increase of their hemoglobin more than 1 gram at some point. Also, there's a reduction on transfusions needs, and this is, I think, in indirect way by increasing their hemoglobin levels, so led to reduction of transfusion needs. The second medication is crizanlizumab. It is a drug, it's an adhesion molecules. So the drug was trying to block the initiation process of vaso-occlusion by blocking the B-selectin. The main trial sustained trial. It is phase 2 trial. They include patient age of 16 and above. There are tried 2 doses, 2.5 and 5 milligram per kg versus placebo. Eventually, it's approved as 5 milligram per kg IV, as the 2.5 milligram did not produce any statistically significant results. So the primary efficacy endpoint was the annual rate of vaso-occlusive crisis, among other secondary endpoints. The baseline characteristics is quite similar. There are more patients who have hemoglobin SS, black, and a fair number of patients really were on hydroxyurea at the enrollment of the study. So it's really decreased the vaso-occlusive crisis frequency by 45% reduction with a dose of 5 milligram per kg versus placebo. Also, this was irrespective of hydroxyurea use. There is a reduction in pain crisis. The median time to the first vaso-occlusive crisis was prolonged, like as you see, like 4 months versus 1 month to placebo. And the median time to second pain crisis also prolonged, as you see, 5 versus 10 months in the crizanlizumab group. Other efficacy endpoints, as you see, like the annual rate of uncomplicated pain crisis were statistically significant, but the annual rate of days of hospitalization wasn't the case. Adverse events, there were non-specific as well. Side effects, back pain, headache, and nausea predominate. There are some serious adverse events reported like pyrexia, influenza, and pneumonia. The third drug is L-glutamine. So L-glutamine, it has anti-reductive capacity. Usually it's depleted in patients with sickle cell disease because it's used by stress red cells. With the losing of anti-reductive capacity, this precipitate vaso-occlusive crisis by oxygen-free radicals. This is from age 5 and above. Also 2-to-1 randomization. It's oral medication for 48-week treatment period. The median annual rate of sickle cell crisis, around 45% reduction. When they initially published the paper, they was using median rather than median annual rate was reduced around 25% reduction. And also the annual rate of acute chest syndrome is less as well. The number of units of red cell transfused over 48 weeks treatment period. Also, there is a reduction in patients who've been on L-glutamine versus placebo. Time to the first sickle cell crisis, it's prolonged. The time to crisis also prolonged and compared to placebo with the using of L-glutamine. Also, the episodes of acute chest syndrome was statistically significant reduction in patient on Endari. The number of emergency visits for sickle cell related pain wasn't statistically significant. The other drug that have been tried is rivipansel. So in this case, they were trying to give anti-adhesion molecules in the context of acute vaso-occlusive crisis, not as a prevention, but as a resolution of a crisis. It is a pan-selectin inhibitor, especially for E-selectin. Around 42 patients. It was given every 12 hours for 15 doses. The main outcome was time to resolution of vaso-occlusive crisis. It was lower in compared to placebo, but was not statistically significant. However, they noticed there is a reduction of IV opioid use while on rivipansel. The second drug being tried, intravenous magnesium for sickle cell pain in children. I mean, there was initially prior to that one randomized trial that showed this positive effect, but eventually with larger sample size, really didn't pan that to be effective. It did not shorten the length of stay or reduce opioid use. As I mentioned, these patients have a lot of activated state of platelets, so they tried prasugrel in children from 2 to 17 years of age. It did not show any difference in the rate of vaso-occlusive crisis between placebo and prasugrel. This is, sorry. Can you go back the slides? I cannot control the slides from here. Go back, where did I stop? At the point I stopped. من هنا ما في كنترول هنا. Okay. Why slides are moving kind of fast, so. Can you go back for a few slides more? Back, back, back. More? That's it, okay. So the other drug is civoparin. It has anti-adhesive properties and lack the anticoagulant effect of flumoroquine heparin with the primary endpoint to time to vaso-occlusive crisis resolution, among other endpoints. It really either intention to treat or per protocol did not produce any difference result from placebo. Also, the effect on pain intensity and duration. Can you go back with slide? It's gonna move fast. And also they looked into cumulative opioid consumption was no different between civoparin versus placebo. So it's not superior really to placebo preventing vaso-occlusive crisis. The other drug, this is a recent trial, it's poloxamine 188. It is kind of copolymer that has antithrombin, antithrombotic and anti-inflammatory effects. It was phase 3 trial. It was given continuous infusion versus placebo. Really, the main outcome was time in hours from randomization to the last dose of parenteral opioid among all participants, and did not really shorten the time to the last dose of parenteral opioids during vaso-occlusive crisis. So it was kind of negative studies. So as you see, there's a lot of randomized trials that turn out to be negative in patients with sickle cell disease, with a few that turn positive. Arginine therapy for acute pain in children with sickle cell disease in Nigeria presented in ASH 2019. It is a phase 2 trial. Arginine was given because it's kind of one of the things that's released from hemolyzed red cells and they play a role into formation of nitric oxide. So age 5 until 17, the outcome was change in the total analgesic medication, decrease in the pain score. Baseline characteristics were similar. So the medication quantification score really significant reduction in arginine arm, analgesic use versus placebo. And the main daily rate of decline in pain scores were faster in arginine arm versus placebo. The time to crisis resolution by day 5, 50% of children on arginine discharged compared to 24% in the placebo. And also the length of hospital stay in arginine arm was shorter than on placebo group. Adverse events, there was kind of trends toward increased vomiting in all arginine arm, but there was no serious side effects observed with arginine. The other thing is case report still with gene therapy. Different genetic tools have been used, the CRISPR, the lentiviral, and they were targeting 3 molecular goals. Either they modify the beta globin chain, they go to gamma globin and induce it to high numbers, or they repair the defective one, either to add or repair beta chain. It is similar in a way to hydroxyurea. One of the limitation of gene therapy that you have still to have give induction myeloablative chemotherapy. So this is just one case of sickle cell disease who have gene therapy. The hemoglobin A in blue color, this is just from the transfused red cells before, and the donor was a sickle cell trait. As you see in the black lines, there is a production of hemoglobin A eventually up to 48%. So in summary, hydroxyurea remain an essential drug. We should encourage it to all patients to use it. It's still old, but it should be recommended to all patients. The crizanlizumab and L-glutamine can be used with hydroxyurea or alone for pain crisis prevention in patients who does not tolerate hydroxyurea for any reasons. Boxilitor, it's the first drug after hydroxyurea to target the disease mechanism. It's well tolerated. So, and as you see, the drug that might work in theory really might not work in reality. And lots of drugs for sickle cell disease died in the preclinical studies. I believe combination therapy, where we combine 2 drugs or 3 drugs, will be down the road part of management of sickle cell disease. That's it. Thank you.
Thank you, Dr. Sultan, for the excellent presentation. So we'll have now the discussion session, and I'd like to ask Dr. Sultan to join us here. Dr. Hatun is still with us virtual, and Dr. Bakar will coordinate the discussion session. Thank you.
Do you have any question?
We'll face the
so that's online. It seems that there's no question, isn't it? Okay.
I have a question.
So there will be a Jum'ah prayer
Dr.
at
Bakar.
the first floor in Masjid, at 12:40. At 12:40.
Bakar, I have a question to Dr. Hatun. Dr. Hatun, just a question regarding the registry. Is it only for the Ministry of Health, or is there plan to visit other sectors of healthcare in Saudi Arabia? And the same question also for newborn screening.
Thank you for your question, Dr. Zahrani. So right now, the registry is happening into phases, just given the budget limitations. So phase 1 did include 25 health sectors at MOH. Phase 2 is another 15 from MOH, but with expansion in the functionalities. We're planning for phase 3, so it wouldn't start until probably 2023. And this is the phase where, inshallah, we will be including other health sectors. The newborn screening is actually the whole kingdom. So it's very similar to what's happening with the newborn screening right now. However, given that we have only one machine delivered to Wiqaya Center, we've started Al-Hassa, but once the 5 machines have landed at the lab, it will be inclusive for all the kingdom, inshallah.
Question. This is Dr. Ali Gregory from King Abdulaziz. To Dr. Hatun, what is the state right now of the success premarital testing, and what is the cancellation rate? And is there any plan for eradication of the sickle cell and thalassemia in terms of the budget for the strengthening the shortcomings of the current premarital testing in terms of timing in terms of having more authority and law in terms of allowing such marriage?
Excellent question, Dr. Ali. Thank you so much. The aspiration actually is to eliminate the disease. And there was a huge focus. However, as everyone can tell, it's a disease that I wouldn't be saying ignored, but however, resources for the facilities and availabilities is always a challenge. But what I could tell you based on analysis, I'm trying to pull it somewhere where I do have it just to show you. We did analysis based on the premarital screening from 2004, since the start until 2018. And then the most recent one we did is the one that I'll show you right now. I managed to get the slide, is from 2004 again until 2020. If you can see my slide, and this is a slide we presented at the summit, and this is the response rate among partners. So it went up all the way from 9% up to 90%, and this is marriage cancellation. With the newer program that they started internally, where the delay is happening for a month and they go through sessions and they actually take them to inpatients. This is what's happening. So that's the aspiration. However, we always think it's fair for partners to have other options too, because remember, the premarital screening could happen only a month before the actual marriage. So it's just unfair to just come to partners and just tell them, yeah, it's better to cancel your marriage and just leave them with this dilemma. For that particular reason, we're working on other solutions like the PGD, availability of appropriate counseling. We could talk to them about spacing and option of one of the GHRAS, the project GHRAS objectives that we're talking about is actually doing the PGD, but at the same time doing HLA for the already diseased kid that they have in the family for an option of a transplant. So it is a program that needs multiple arm of works, multiple institutions and stakeholders. It's just not easy to say eliminate, but it is the aspiration.
Question for cancellations is excellent outcome in 2020. Prof. Musa has a question.
Question for Dr. Sultan. How do you see the future perspective for gene therapy in sickle cell disease?
طبعا now gene therapy is one or the second thing that may be curative therapy for patients with sickle cell disease. I mean, it's maybe limited now for patients that didn't have any match for bone marrow transplant. The issue with gene therapy, the positive side that you don't have risk of graft versus disease. It's similar to autologous stem cell transplant in a way. Still downside there is you have to give conditioning chemotherapy. I think one of the main also barrier is the cost of the medication for its implication in our practice. So so far it seems like bone marrow transplant would be cheaper option and compared to gene therapy in application.
About long-term safety.
Well, there are case reports so far, and it seemed like long-term safety is fine. I mean, except that you still have risk with the chemotherapy that you give it, the conditioning chemotherapy, that you might have myelodysplasia down the road. That's basically the principle. And just a question to the doctor about the civoparin I presented. It lacked the anticoagulant effect of heparins. It had the anti-adhesive properties, and it was like ineffective in compare with how different from the sulfated hemoglobin. Heparins.
That's a good question. In a way, civoparin, in a way, as you can see, was suboptimal. It did not meet the endpoints criteria, and one of the key reasons, in a way, why sulfated non-anticoagulant heparin would be, because we totally eliminated not only weakened anticoagulant, we eliminate the systemic anticoagulation. We can dose it, normally the dose of low molecular weight heparin is about 1 milligram per kilogram in human subject. As you can see from Lovenox and Suvaberin and any molecule with anticoagulant activity, you have to limit the dose. If you go higher with, say, enoxaparin, you're going to have a serious bleeding side effect. You're going to have the patient will bleed to death. With the we have done extensive studies with the sulfated, it's totally devoid of systemic anticoagulation. We can dose it up to 100 milligram per kilogram, 300 milligram per kilogram. This is where you can realize the full potential in terms of anti-selectin, anti-inflammatory activities, because it's a function of the dose in a way, but without the red light of bleeding side effects. That is a key difference. The other thing is the sulfation enable us to have a tight adhesion to the endothelium and protect the endothelium and release tissue factor pathway inhibitor locally within the endothelium to prevent local vascular thrombosis. That's something beside the engineered anti-sickling effect, which does not exist in Suvaberin. So you have a very powerful anti-inflammatory effect is superior. It releases nitric oxide from the vascular endothelium because it does bind to the endothelium. And then we increase the circulating half-life because Suvaberin has a very short half-life, similar to SNH if it is given without formulation. So having the nano formulation enables us to have a sustained blood level and high vascular entrapment to get us protect the endothelium. It's about the endothelium is the key, and provided that you can have enough circulating blood levels to take care of the sickled red blood cells. That's a major differentiation. Thanks so much for that question.
Thank you for all the speaker, and we will conclude here. And just a reminder, there will be a Jum'ah prayer at first floor at 12:40. Thank you for everyone.
So we'll be back at 1:15. Thank you very much.
of life of hemophilia patients. The agenda, as you see, introduction, diagnosis, comprehensive care, and advanced treatment of hemophilia. Introduction, as you know, the hemophilia is an X-linked disease in factor 8 and factor 9. Usually it's in the male patient, more common than the female. It's a rare disease in females. As you see, how is this distributed in a family with a father and mother, which is a hereditary or carrier hemophilia gene. As you see, the son. Hemophilia A is much more common than hemophilia B. Account for about 80% to 85% of all hemophilia disease. Prospective study report that over 50% of people newly diagnosed with hemophilia with no family history. Most of them are being, most of the hemophilia can be acquired as a result of development of autoantibodies, most commonly directed against factor 8, including a variety of conditions, including pregnancy, malignancy, and autoimmunity diseases. Hemophilia have a negative effect on the quality of life of hemophilic patient, of course. And this can be due to a variety of hemophilia-related issues, such as a bleeding episode, pain, decrease in functional capacity, and impair their performance at school, work, and recreation. Diagnosis can be suspected in individuals with a history of any of these symptoms, such as an easy bruising, spontaneous bleeding, bleeding from joint muscles and soft tissue, excessive bleeding following trauma or surgery. Early symptoms of joint bleeding in children at a very young age are the key indicator of hemophilia. Hemophilia suspected, or the clinician should obtain the patient sibling history, a maternal cousin, uncles, grandfather, or assist pattern of inheritance and assist with diagnosis. Accurate diagnosis of hemophilia to inform an appropriate management. The key based on a factor SA to determine deficiency of factor 8 and factor 9. Comprehensive hemophilia care, usually it needs the multidisciplinary medical services necessary for the diagnosis, treatment, management of the condition, and its complication. Comprehensive care will promote physical health and physico-social well-being and quality of life for people with hemophilia and reduce morbidity and mortality. Priorities in hemophilia treatment and care include prevention of bleeding and joint damage, pain management, management of musculoskeletal complication, prevention of management of inhibitor, and quality of life assessment and physiosocial support. Advance in treatment of hemophilia, current management of hemophilia A and B is giving the primarily includes the prophylactic factor, factor 8, factor 9, and of course the Nova 7 or factor 7. It begins in the early 50s with the fresh whole blood, the whole plasma, fresh frozen plasma, cryoprecipitate, factor 8, factor 9, and of course factor 7. A major issue with the replacement factor is their immunologic potential, neutralizing antibodies, known as the inhibitor. Inhibitor against the factor, approximately 30% in hemophilia A and 3% in hemophilia B. The development of these inhibitors can complicate the management of hemophilia patient, and that will affect the quality of life of these patients. Hemophilia management, significant impact on quality of life. Frequent factor administration is not only disturb the daily life, but can also lead to vein damage and scarring potential, which is resulting in poor compliance. Improving hemophilia management remain important aim and has attached to a large amount of research and direct effort for novel agent to overcome the event that impact the quality of life of hemophilia patients. In early 1950s, we have, of course, the whole blood, which is given for this patient. Then we have the FFP and cryoprecipitate to the fourth generation in 2015, when we have the fourth generation of factor 8 and factor 9. Extended half-life product is one of the major change in treatment of hemophilia and that by increase the half-life time of the factor 8 and factor 9, usually by the one of the three method of the pegylation of the phenyl by the pegylated, the FC fusion and albumin fusion. The first approach fusing factor 8 and factor 9 to a protein with a long half-life, albumin and FC fusion of IgG, and that will increase or extend the half-life of factor 8 and factor 9. The FC fusion has been applied to both factor 8 and factor 9. Albumin fusion has been applied to factor 9, produce what known as the Alpture Ibn, I don't know the name, it's a very long one. The second method of the pegylation is the severe pegylated factor 8 products, such as the alpha Begol and currently in clinical use. And that increase the half-life of prolong the half-life time of the factor 8 to 1.5 to 1.6 fold, and the factor 9 to increase the half-life time for them to increase in 5 times more than the standard time. This is the pathway of blood coagulation, activation, factor 9, as you see. The third method used to increase the stability of factor 8, and also increase the affinity of increase the affinity of von Willebrand factor therapy, and that will decrease the clearance and prolong its circulation half-life. The low-noctuc alpha is a novel B domain, and it is a single chain and covalently linked to factor 8 chain. Despite the impressive results seen for extended half-life, product are not without a limitation, of course, because it is till now it is an intravenous route, and that still we have incur the complication related to this route. Another issue of this improvement of half-life of factor 9 product is greater than the factor 8, and that, of course, because of the half-life time of factor 8 is limited by the half-life of von Willebrand factor, and that will modify the modify the improvement of factor 8 over factor 9. The last thing of the extended half-life product have shown a great promises as an alternative standard factor replacement, reducing administration frequency and improving the patient quality of life and prognosis. However, there is a lack of comparison between each of these extended half-life products. Ongoing trail overcoming the drawback of extended half-life product is the listen track of time. Phase 2. I'm sorry. Okay. Despite the progress made with the availability of clotting factor, unmet need remain for the optimal treatment of the patient with hemophilia. Remarkably, the current available extended half-life factor 9 and factor 8 product reduce administration frequency, but the treatment is still required to be administered by the infusion with attend challenge associated with venous access, particularly in young children. So we have the same problem, the problem of hemorrhagicity of exogenous administrative concentrate. The most serious adverse effect of replacement therapy remain a problem. The incidence of allo antibodies in factor 8 and factor 9 occur about 25% and 3 to 5% in patients with severe hemophilia A and hemophilia B. Considering the above observation, novel molecule to replace the hemostatic system in patients with hemophilia have been developed to be less and more effective. This novel agent act as rebalance the coagulation system by enhancing coagulation, such as the emcizumab, or inhibiting the anticoagulant pathway, such as the fituran and concizumab. Emcizumab is a recombinant humanized bispecific IgG antibody, which mimic the cofactor function of the missing factor 8 in hemophilia A. طبعا الامcizumab will, as we mentioned here, it will enhance the coagulation. And it has a long half-life. طبعا الامcizumab will be taken maybe once a week or once every 2 weeks, or maybe even for once a month, and its half-life is more than 4 to 5 weeks. It is a subcutaneous route of administration. Emcizumab can reduce the treatment burden associated with frequent intravenous factor infusion. So it is a very, very promising drug. The cost effectiveness also, it goes from $260,000 to $179,000, and this will direct effect of the quality of life in hemophilic patients. Alfitsuran, it is the other pathway in fitsuran, and alfitsuran, it will inhibit the anticoagulant. It will inhibit the anticoagulation, and that by the novel consists of the amino acid in acetyl-galactosamine, the line of hepatic acetylglycoprotein receptor conjugated to the synthesis of the siRNA. As you see, it will inhibit the antithrombin synthesis. It is also once monthly. It's taken subcutaneous injection, and this will improve the patient quality of life and likely compliance compared to current regimen. The concizumab, it is an IgG4 monoclonal antibodies targeting tissue factor pathway inhibitor. It presents an alternative therapy of hemophilia A and B patient, both with and without antibodies. What is it? A prospective study is ongoing. No, the improvement of quality of life of concizumab compared to conventional factor 8 was explored in survey involving explorer and practice taken as a baseline in 24 weeks. طبعا the concizumab group experienced an improvement for baseline the pain catastrophizing scale score and improvement in bodily line, physical function, health, vitality score, and social function. Gene therapy offers the possibility of eliminate the need of repeated administration of a medication to prevent bleeding, enhance the quality of life, and proven the spontaneity people with hemophilia lack due to its single administration paradigm. The ultimate goal of hemophilia treatment should be functional cure and health equity. Gene therapy research has explored various mechanisms for transgene delivery, including the non-viral technique, including chemical, electroprotein, polymer-based procedure. However, the viral-mediated delivery, such as the lentiviral, adeno-associated, or gene editing of an transgene encoding the information necessary for the patient, for the recipient cells to express factor 8 and factor 9 protein, potentially cure the patient. Hemophilia has been most commonly used. Recently, efforts have focused on the adeno-associated virus as a preferred delivery method. Although 3 trials currently underway will utilize the lentiviral gene delivery combined with autologous stem cell transplantation of patients with hemophilia A, and 1 trial for hemophilia B, and 1 trial for patients with hemophilia B is underway using a gene editing approach. As I see, either by transplantation of cells, the cell expressing coagulation factor, or by direct injection of vectors. A core set of outcome measure was described by the Lurio et al. And include the frequency of bleeding event and the achieve of factor 8 and factor 9 level, the duration of transgene expression, elevation of chronic pain utilization, healthcare resources, and mental health. To date, the data from the completing and ongoing clinical trial of gene therapy on hemophilia A and B have demonstrated benefit in terms of reduction of bleeding frequency and the need for supplement infusion factor 8, factor 9 concentrate treatment, breakthrough bleeding event. However, data support the benefit in the other core outcome parameters are lacking. The conclusion thing that a comprehensive hemophilia care involve multidisciplinary medical services necessary for diagnosis, treatment, management, and of the condition and its complication. Hemophilia management significant impact to the quality of life. Improving hemophilia management remain an important aim and has attached a large amount of researches and direct effort for novel agent to overcome the event that impact the quality of life of hemophilia patient. Recent advance in treatment of hemophilia using novel agent improve the quality of care of hemophilia patient. Ongoing studies are aiming to reach the functional cure and the health equity. Thank you.
Thank you, Dr. Assam. We'll just, if you have any question for Dr. Assam, because he has urgent issue that he might not be with us during the discussion. So, تفضل Dr. حافظ.
Yeah, thank you, Dr. Assam. My question, unfortunately, we have a significant number of patients with advanced joint damage, mainly hemophilia A. Is there, how, from your aspect, from quality of life, how we can improve, especially with the multiple drugs or products you are talking about?
Hemophilia A, which is more common than hemophilia B, this is one of the problems. I think one of the most common and important problem is the antibody against the factor itself. So to overcome these, one of the, either by the fituran or the emicizumab or one of these novel treatment is the only way to overcome this problem. And for me, seriously, as I discuss it with Dr. Ali Gregory maybe and the professor on lunch, that is one of the most important thing is the gene therapy, which is now have a lot of success stories in King Faisal Specialist Hospital. This is from my own opinion, Saraha, and I support this this method.
A question or comment for Dr. Assam? Thank you, Dr. Thank you, Dr. Now it's our pleasure to introduce Dr. Abdullah Al-Muhammadi. He's a graduate from King Abdulaziz University in Jeddah, Saudi Arabia, 2007. He completed the Internal Medicine American Board in 2017 and Hematology American Board in 2019 with Oncology American Board in 2019. He became a research trainee in Internal Medicine Training Program at the University of Toledo, Ohio in 2012 and pursued his Internal Medicine residency in Detroit Medical Center and University in 2013 till 2016. Later, he completed his hematology oncology fellowship at Michigan State University 2016 and 19. Currently, he's a clinical hematology assistant professor at King Abdulaziz University Hospital. Dr. Abdullah will talk about international recommendation on the diagnosis and treatment of acquired hemophilia A. Dr. Abdullah, the floor is yours.
Thank you very much, Dr. Iman. Assalamu alaikum wa rahmatullah. It's a pleasure to be able to speak here, and I'll talk about some guidelines on acquired hemophilia. I'll start with the introductory slide. Acquired hemophilia characterized by the formation of neutralizing autoantibodies against the factor VIII, which is different from the congenital hemophilia, which is a group of rare genetic disorder caused by mutation in the gene encoding for certain clotting factor. It has a it's a very rare disease, and the incidence actually 1 to 2% per million per year, and it affects male as much as female. It's different from congenital hemophilia. Here, the hemoarthrosis is infrequent, and the ecchymosis is the most common manifestation. Intracranial hemorrhage is rare, but can be fatal, and postpartum and post-surgical changes, postpartum and post-surgical bleeding. And there is no clear correlation between the factor VIII level and the bleeding tendency. We tend to think in congenital hemophilia that patients with factor VIII less than 1% are more prone to more serious bleeding. Here, the patient can have a serious bleeding with a factor VIII of 3 or 4. If we look at the major European registry, we see almost half of the patient will not have an obvious cause for the acquired hemophilia. On the other hand, the other half will have a clear association with other conditions like autoimmune disorder, malignancy, and postpartum. If you look at the age and sex distribution of the patient with acquired hemophilia, we see that we see in the dark blue the males and in light blue the females, and we see that the incidence of the patient are in the 70s and roughly 50-50 split between males and females, apart from the other younger group, which is of course predominantly female, and this is the postpartum acquired hemophilia cases. The diagnosis should be suspected in elderly patient or postpartum cases if they have isolated prolonged ABTT with a normal BT. And after we do the mixing study, it will usually fail to recorrect and reprolong after 1 or 2 hours of incubation. And to confirm the diagnosis, we need to have a reduced factor VIII level and evidence of the inhibitors. I believe heat inactivation of the test plasma will improve the assay sensitivity. And one of the problems of these patients being elderly is there's other differential diagnosis for the prolonged ABTT. One of them is lupus anticoagulant. And we can get around this by doing a chromogenic assay, which is insensitive to the lupus anticoagulant, or by having a negative diluted aerosol vapor venom test. And the last point, which is really need to be emphasized, is that inhibitors in congenital hemophilia usually display a linear type 1 kinetics. But here, the inhibitors are different. They usually display a complex and non-linear type 2 kinetics. So the assay will not be able to estimate the true potency of the autoantibody. Spontaneous remission has been reported in some postpartum cases and cases secondary to drug. And this is usually take few months. Also, it's been reported in individuals who have a low inhibitor titer, and the exact percentage of these patients that undergo spontaneous resolution is unknown. Patients should be managed in conjunction with specialist hemophilia center and try to avoid any invasive procedure. Of course, treatment of the underlying cause may help. And most importantly is that the decision to initiate treatment is guided by the clinical relevance of acute bleeds. So given that there's a lack of correlation of factor VIII and inhibitor titer and the bleeding phenotype, so they should not influence the decision to initiate treatment. The treatment depends mainly on two specific arms, controlling and preventing bleeding and eradication of the inhibitors by using immunosuppression. So bypassing agent is recommended to be the first line management for acute bleeding. We have recombinant activated factor 7 and activated prothrombin complex concentrate. If we compare them to the factor 8 and desmopressin, they have high level of effectiveness. In the large H2 registry, the bleeding control was higher by using bypassing agent was 93% compared to only 68% on the factor 8 and desmopressin arm. And if we compare them to each other, there's no significant difference between them. The efficacy of activated factor 7 in acquired hemophilia was recently addressed in a systemic literature review, total of 12 studies, including more than 671 patients, and they treated more than 1,000 episodes of bleeding by recombinant activated factor 7, and the median age was 90 microgram per kg, and they repeated every 2 to 3 hours. And the efficacy was more than 90%, and the thromboembolic and cardiovascular event was assessed in 8 of the 12 studies and was ranging between 0 to 5%. The ABCC, there's no systemic review of the product used in acquired hemophilia. The recommended dose is 50 to 100 units per kg and repeated every 8 to 12 hours, up to a maximum of 200 units per kg per day. In H2 registry, more than 90% of the bleed control rate when used as a first-line treatment, and the thrombotic events was 4.8%. ABCC is contraindicated in patients with signs of DIC. Given that we don't use the porcine factor, I will not spend that much time. I will not spend any time on this slide. The role of human factor 8 is in the absence of bypassing agent, and if the inhibitor's titer is low, below 5 Bethesda assay. Let's turn to the question of inhibitor eradication. Immunosuppression is recommended in all adults with acquired hemophilia. We all know that we recommend to start the patient on combination of prednisolone and cyclophosphamide. And the data indicate that majority of the patient, up to 80%, will achieve remission after a median follow-up of 5 to 6 weeks, which is a little bit longer than many physicians feels is necessary for treatment. Cyclophosphamide is not safe during pregnancy and lactation, so of course it's contraindicated in the postpartum cases. Without going into details, we know that a combination of steroid and cyclophosphamide will yield into better result, and of course more adverse event, but interestingly that it will not affect the long-term survival of the patient. The prognostic factor for remission and survival, the German study identified that factor 8 less than 1% is a poor prognostic factor. So the author now advocate an individualized treatment. So if the patient have factor 8 more than 1 and the inhibitor less than 20, we should considering starting the patient on monotherapy with corticosteroid. But if the patient has a factor 8 less than 1 and the inhibitor titer more than 20, we should consider starting the patient initially on combination therapy. At this point, we know from many studies that factor 8 less than 1% associated with lower remission and survival rate. Roughly 20% of the patient will relapse after 6 months, so they should be closely monitored as outpatient. The German study also showed that patients with anti-factor 8 autoantibodies of IgA class are high risk of relapse, but which is a difficult test to do. But much more importantly is that a French study published in 2019 showed that decrease in the factor 8 of volume-brand antigen ratio less than 0.7 is an early useful indicator of relapse. Despite the new enthusiasm on rituximab use, it's not recommended as initial monotherapy because the chance of achieving remission is lower than conventional therapy. How about alternative therapy? Alternative therapy should be considered in patients who fail to see a decline in the inhibitor or rise in the factor 8 level after 3 to 5 weeks. I've talked about rituximab as initial therapy. We can use rituximab at either one of its classic dose as a second-line therapy or for the relapse patient. Other agents can be used are including cyclosporin, mycophenolate, intravenous immunoglobulin is not recommended, and emicizumab is not recommended outside the clinical trial. So in conclusion, acquired hemophilia is a rare but often undiagnosed condition. Patient usually elderly and associated with other conditions like malignancy, autoimmune disease. There's significant risk of serious or fatal bleeding. In some studies reach to between 9 to 22%. Patient should be supervised by specialist center. And of course, the treatment include two specific arms, treatment of the acute bleed and eradication of the inhibitor by immunosuppression. And the last point, factor VIII less than 1% and factor VIII over von Brandt anti-G ratio less than 0.7 consider a poor prognostic factor. Thank you.
Thank you very much, Dr. Abdullah, for this excellent talk and for being on time. I think we have some time for any questions, Dr. Abdullah. Does anyone have any questions for Dr. Abdullah Mohammadi? Okay, I will start. Thank you very much for this talk. I know we have been using recombinant factor 7 and FABA for quite some time for activated for hemophilia A with inhibitors, as well as acquired hemophilia A. Do you see any future medications or treatment strategies that might arise in the next coming years, especially emicizumab? Is there any role for it in this current era or no?
There is some studies on the emicizumab, but until now, the safety and the efficacy is not unknown. So until we have more data, I think up to this point, there is no role outside the clinical.
Any further questions? All right, thank you very much.
Yeah, may call on Dr. Inshira to introduce our next speaker. Is she here? Dr. Inshira? To introduce Dr. Yes,
So,
Dr. Inshira is here. Inshira. Is Dr. Hafiz around? Yeah, so she's supposed to be, he's supposed to be introduced.
Yes.
Anyway, Dr. Inshira is not here, so you can proceed.
In the hope of kind of staying on time as well as we're doing at this point, I would like to introduce Dr. Hafiz Marhan. He is our next speaker. He is actually a sponsored talk by Novartis. This is a satellite symposium event. Dr. Hafiz is a consultant adult hematologist at Prince Mohammed bin Nasser Hospital in Jizan in Saudi Arabia. He became the head section of the adult hematology department and since March 2015. He is also the director of the oncology center over there since March 2014 and to February 2015. Today he will talk about sickle cell disease and mainly focusing on the cycle, beyond the cycle of pain. Dr. Hafiz, the panel is yours.
Okay. Thank you, Mr. Chairman, for introduction, and thank you for the organizing committee for invitation. Today I was requested to present about our experience in Jizan in sickle cell anemia for management of refractory painful crisis. How to move? Yeah. Okay, so as you know, sickle cell disease is one of the severe and common disorders that include congenital hemolytic anemia as caused by inherited point mutation in beta globin gene, and that result in different pathophysiological changes in the body from erythrocyte rigidity, vasculopathy, vaso-occlusion, and hemolysis, and with result in profound clinical consequence as vaso-occlusive crisis with wide spectrum of manifestation from stroke, acute syndrome, priapism, and etc. Hemolytic anemia is one of the major signs of chronic manifestation of the disease. All result in multi-organ dysfunction plus or minus infection that unfortunately result in premature death for our patient. So the old paradigm for patient with sickle cell anemia, as all we learned from the medical school, sickling, result in vaso-occlusion, result in ischemia and the manifestation of it, and the discovery of the new and multiple pathophysiological changes and causes of manifestation of sickle cell anemia with a strong and complicated interrelation between each other, include inflammation, coagulopathy, chronic hemolysis, red blood cell changes, and interestingly, endothelium dysfunction result from different factors, including the reperfusion, ischemia reperfusion injury. So is multi-system disorder, including from the body from the head to toe, with the major and minor complication and presence of aggressive behavior in some patients, especially in our region, and with presence of variation in the clinical presentation, even between the sibling in the same family. Painful crisis represent more than 90% of admission, and 85% need acute medical care for those patients. And I have postulated some ideas and thought about how we can improve this thing. Number one, I think patient education. We need it as much as we can, especially in our busy clinic with new requirement, KPIs and so on, requested from the consultant in the clinic. No time to get a good patient education. I think the role of health educator in our system is very mandatory. Psychological assessment is very important for our patient, especially they have good significant or good number of patients, they have depression, they have mental status changes, and that will result in causing more vaso-occlusive crisis. Premarital counseling is one of the preventive programs established by MOH more than 10 years with good outcome, but still we need more and more effort to convince our patient, our community to have a healthy marriage program. False perception from both sides, from the patient and from medical healthcare provider about the sickle cell anemia. Social evaluation is again another important for our patient. We have seen some patients, they don't get approached to their medication, especially hydroxyurea. And finally, after 1 month, they will get more and more visit to ER. And another factor for financial support and this issue that will help them. We all notice that there are some restrictions regarding the financial support for our patient regarding the level of hematocrit requested more than 70% to get the financial support. And there was a good effort by Dr. Hatoun and her colleagues to convince the other ministry, I don't know the name is rehabilitation ministry or something like that, but still the process in evaluation. BMT capacity enhancement for our sickle cell anemia patient is required, especially most of the BMT beds recruited by leukemia patients. Research, another factor is important in our patient to discover more and more factor related to vaso-occlusive variation in the clinical phenotype of our patient. Infertility by male patient, especially some they are looking for a stable life and they need kids. In presence of hydroxyurea, it seems difficult, and they need more advanced treatment for them. At the last one, I think we need real magic drug for our patient, and they deserve it to have a good life of care. So any changes of in standard of care, the current now, yes, we have a change. I think the number one, the lack of reliable biomarker. So in our team or in our practice, we are depending mainly on the subjective clinical outcome. And most of the patient we have more dependent and more addicted patient to narcotics, and that will make the decision a little bit difficult for us and for the patient. And unfortunately, not all patients responding to hydroxyurea. I like hydroxyurea very much. There is very successful drug in more than 80 to 90%, but still there are some patients they are not responding. Again, side effect of hydroxyurea like cytopenia, GI upset, infertility issue, also another limited factor for hydroxyurea. Limited alternative options to hydroxyurea and false perception to hydroxyurea by patient about cytotoxicity and the weight gain, especially in female patient. So our experience, as you know, Jazan, we are in the most southern and part of the kingdom. We are the second smallest city in the kingdom. We harbor around 1.6, at least 1.6 million population, and we have 2,100 patients registered in our hospital. But the number more and more than this, and we have at least 5 patients newly diagnosed or newly joined our clinic every week. Most of the patients in our region come from the south part of the region to the east and to the northern part of our region. This our hospital, Prince Mohammed bin Nasser Hospital, is around 200 bed capacity with oncology, hematology, cardiology, and pathology services. This represents the haplotypes in the world, and in our region we harbor the Benin type as compared to Arab Indian haplotype in the eastern region. So Benin type with a low level of hemoglobin F and more severe phenotype presentation for our patient. And this represent the total patient in daycare unit for monthly or every 6 week transfusion program accordingly to the cause. We have up to 312 patients, represent 82 patients, 82% from the whole patient in the daycare. Another beta thalassemia represents 61 and alpha thalassemia 3. This explained the variation between our patient in the daycare. We have currently 98 patients with CNS crisis, some under process for bone marrow transplant and other waiting to get a donor. We have 84 patients with refractory and recurrent vaso-occlusive crisis, painful crisis, that they are not responding to hydroxyurea, and they are on monthly or frequent monthly blood transfusion. Another variety of patients with acute chest syndrome, sickle cell hepatopathy, and pulmonary hypertension up to 13, priapism 12 patients. Interestingly, we have a good number of patients, they respond to hydroxyurea with increase in the hematocrit and the hemoglobin. And what we do in the opposite to do venous section to prevent viscosity to prevent complication for them. Pregnant sickle cell disease, all the pregnant with sickle cell disease in our region, immediately we schedule them in daycare unit for frequent blood transfusion to prevent the complication. Chronic kidney disease up to 6 patients, some of them already established chronic hemodialysis. We referred up to 83 patients for bone marrow transplant, and they have successful program with very less mortality, up to 2 patients in the all patient, and 60 patients in the process. They have already matched donor, and 44 patients waiting for bone marrow transplant, and unfortunate patients 16, they don't have a matching donor. 30 patients, they refuse the bone marrow transplant for social reason, for some false perception about bone marrow transplant, and the total patients who are for bone marrow transplant up to 230. I would like to share with you some of the difficult cases in our center. We have a patient with 30 years old, female patient with sickle cell anemia with recurrent DVT up to 3 times, currently on warfarin after she failed apixaban. She had history of acute chest syndrome and AVN on hydroxyurea 1 gram per day. She had twice COVID infection with good outcome to treatment. And unfortunately, she refused the exchange transfusion due to hemolysis that she noticed many times after the blood exchange, and increase in painful crisis severity that is not one explained by the exchange transfusion that we expect she will get improved. She had refractory painful crisis with frequent visit to ER, and she is narcotic dependent. And she's mother of 5 kids, and she's not tolerating higher doses of hydroxyurea to overcome the painful crisis. So recently we started her on crenezumab, and she unexpected, she had profound response after 3rd doses. And she is still now, she is in 5th or 6th cycle of the treatment, and she's doing fine with decrease in the amount of narcotic dependence. Another patient, male patient, 28 years old, with sickle cell beta thal plus, recurrent acute syndrome twice. He is in hydroxyurea 1.5 gram per day with refractory painful crisis and frequent visit to ER 2 to 3 times per month to emergency. We referred him for bone marrow transplant, but there was no matching donor. And he came back to our clinic with the daycare. We started on crenezumab, and he reported significant response, especially after the 2nd dose, with more than 50% response or decrease in the severity of painful crisis. I will share with you this our experience for all patients. We have started on crenezumab, up to 11 patients we started. 8 of them are female, 3 of them sickle beta thal, others homozygous. They have at least 2 visits to ER per month. And if you see some patient up to 20 visits per year, very frequent visit. And what we noticed, very good response on vaso-occlusive or painful crisis. Majority, they have more than 50% reduction. We have 2 patients discontinued the treatment because there is no improvement. And most of the side effect, nausea and vomiting. And interestingly, there was one patient, she had more severe painful crisis after maybe the 3rd or 4th dose, so we discontinued the medication. So in summary, for this patient, we have, as mentioned, 8 female, most severe cases were selected for this medication. Very good response in up to 70% of those patients. And we noticed early response in 2 patients. They represent 18% after 2 to 3 doses. And majority reported more than 50% reduction in the crisis severity with significant less or no ER visit for some patients. The most adverse effect, it was nausea and vomiting in 2 patients, and only one more severe crisis in 1 patient and was discontinued. Overall impression, I think till now, still we have almost 6 months from the starting the treatment, is very good alternative to difficult cases with refractory painful crisis. And we need more and more time and with more experience for our patient. At the end, thank you very much. I think my team, Dr. Bakkar, Anas, Dr. Hayat, Dr. Fahad, and other team, thank you very much. And thank you for you.
Thank you, Dr. Hafiz. Excellent, concise presentation. So if anyone of the audience have any question for Dr. Hafiz, we can start. Okay.
Thank you, Dr. Hafid. I would like to ask about the 11 patients who were started in crenezumab, whether they all were they all on hydroxyurea, what dose they were, and when they show response, we were able to decrease the dose or we maintain the same regarding hydroxyurea for those patients.
Who have serious event?
No, I mean if the patient are in they started in crenezumab, were they all on hydroxyurea? And if yes, what is the average dose they were requiring? And we were able to decrease, like we know how patients are reluctant to start hydroxyurea or maintain hydroxyurea. Were they decreasing the dose of hydroxyurea when they show response?
Yeah, I think the patient, most of the patient that we say, as mentioned, it was selected patient for those who are not tolerating hydroxyurea, for those who we cannot give the higher dose of hydroxyurea, or some of the patient, you know, the second case is 1.5 gram, but still he has more crisis. So we are not on the clinical trial. The selection criteria, we are a little bit complicated because of the low amount of the drugs. As you know, we have more and more customers, they need the medication. We are selecting the more complicated cases. Those who are not responding, I think, because one patient, he had more painful crisis than before. I think this by exclusion, I cannot repeat. I have one patient, maybe was not mentioned. She had 3 doses or 4 doses. She felt very well. She thinks she doesn't need more medication, as she continue on hydroxyurea. Another patient, she couldn't tolerate again, and we discontinued. To try again, I don't know about this. I think because of the high number of the patient, we immediately get another replacement by another patient.
My question, Dr. Hafid, regarding the need of allogeneic stem cell transplant. You're still referring all the patients with a major complication for transplant. If no matching donor, later we are starting the crizolizumab. Because I see in your presentation, no matching donor. So
we have up to 60 patients. They have no match donor. We again to another program of haploidentical of haplotransplant program from the National Guard. They are doing this, but also is not all patients they getting this chance. We refer to blood exchange. If there is no benefit, we'll go to crizolizumab. As I told, we have more customers and we have low amount of drugs for this.
Any questions from the audience?
Okay.
Okay, thank you so much, Doctor. Thank you.
Because our next speaker will be virtual, we'll just double check that Dr. Mervat is ready, as we are like 20 minutes or 15 minutes ahead from the schedule. So we'll just make sure first that she's ready online.
Yes, hello, good evening. It is my pleasure and assalamu alaikum. It is my pleasure and honor to be here. I sent a recorded presentation. So if it is ready, they can show it. If not, if you want me to share my slides, I can do that. But it is my pleasure and honor to be with you, although it is virtual. And I think it's a very important meeting. It's there every year and it's bigger and bigger. Thank you so much. Will I share my slides, or is the recorded presentation to be shown on your side, please?
Whatever you like, Dr. Mervat, if it's more convenient for you to share, it's up to you.
I prefer the recorded meeting, please. Yes.
Okay, sure.
And I will be available for questions.
Sure. So would like to welcome Dr. Mervat Matar. She is a professor, clinical hematology unit, internal medicine department at Al-Asr Al-Aini faculty of medicine, Cairo University. She's also the head of clinical hematology department at Armed Forces College of Medicine, Egypt. It's our pleasure to have her virtually giving a talk about one-brand disease in childbearing age. Welcome, Dr. Matar. The floor is yours.
Excuse me, I think they should start the slide show. Or do I do it myself? I don't know.
Dr. Merve, are you with us or we lost you?
Okay. Shall I flip the screen myself? Because I thought they were it was a recorded presentation. It was a video presentation. But if you can hear me, I can flip the slides myself.
Okay.
Which would you
we can
prefer?
see the screen, Dr.
Yes,
Merve.
but you cannot hear me.
We can hear you. Now we
Okay.
can hear you.
Okay. Okay. Let me just try. It doesn't flip. Yes, it does. Okay, so today we are going to discuss von Willebrand's disease in women of the childbearing age. It is my pleasure and honor to be here. Thank you very much for hosting me. And I think this is an important problem in our region. So, as we all know, there are many types of von Willebrand's disease, and the mild type, which is type 1, there is a quantitative decrease on von Willebrand factor and also in factor 8, but the ratio is preserved. With types 2, there are many subtypes of type 2. These are more severe, and especially with the type 2b, you can get also an associated thrombocytopenia. Type 3 is the worst, with absence or near absence of von Willebrand factor. And these are the ones that we really need to worry about the most in the childbearing period. Regarding inheritance, thankfully, the inheritance of most cases of types 1, 2A, 2B, and 2M are autosomal dominant, but the severe types, that is type 3 and maybe type 2N, these are inherited as autosomal recessive. Genetic test is considered in families with subtypes 3. Regarding von Willebrand's disease in the Arab world, there are not many publications. However, there was a very good publication that involved 2,000 university students in Saudi Arabia, and only 1.6% with von Willebrand's disease was noted. This is in contrast to Egypt, where among 359 included with some bleeding tendency, they found 17.8%. So probably we will be needing to merge our data and continue to register more patients, because this is a disease that might be missed. The challenges in childbearing period are great. These start with heavy periods as of menarche, hemorrhagic ovarian cysts and abdominal pain, or even intraperitoneal hemorrhage. And these patients, they sometimes do not present because of the bleeding, but they present because of anemia. And the patient has continuous or recurrent iron deficiency anemia. She never mentions the menstrual bleeding. Heavy menstrual bleeding is that lasting more than 8 days, consistently soaks through one or more sanitary protections every 2 hours or multiple days, requires the use of more than one sanitary protection item at a time, requires changing sanitary protection during the night, associated with repeated passing of blood clots, or a pictorial blood assessment chart score of more than 100. And this is how it shows. Let me just flip. Each woman is asked to look at what is the type of bleeding, how heavy the bleeding, and how many tampons or pads she changes a day, and then the score is made. So how to prevent bleeding? Number one, you have to prevent hemorrhagic ovarian cysts, because you want to protect future fertility. And this is only done by contraception, either by using the combined hormonal contraceptive orally or by the intrauterine hormonal device, which is better in reducing menstrual bleeding, but does not give protection against recurrent hemorrhagic ovarian cysts, unfortunately. Tranexamic acid can be used in mild cases, and of course, continuous iron supplementation. If not, then you need to use either desmopressin or maybe even factor replacement with each cycle. Regarding pregnancy, this is another story. You have to take care of the mother, you have to take care of the neonate, and you have to have a multidisciplinary team with the hematologist, the clinical pathologist, the blood banker, the gynecologist, of course, and even the anesthesiologist and the neonatal care doctors. Let us see. With pregnancy, factor 8, von Willebrand factor antigen, and also the ristocytine cofactor increase with time. And so even in mild types of von Willebrand's disease, you get an increase of the 3 or some of these factors. And so some of the patients can make it through pregnancy and can have almost a normal delivery with no excessive bleeding, but not all of them. Let us see. With type 1, they say it might be better because there is progressive increase in these levels throughout pregnancy with a peak at the time of delivery. And so they do not have a problem as long as the VWF and the factor 8 levels are more than 0.3 international units per milliliter. So this might be in favor of these poor cases. However, types 2 and 3, maybe they do not do that well, because if the ristocytine cofactor does not increase with time, then the patient might bleed, especially with delivery. And also with type 3, you do not have an increase of the factors at all with pregnancy. So the patient is still vulnerable and liable to treat. And if you have an added thrombocytopenia, for example, cases 2B subtype, then still you will have bleeding with delivery. What about the challenges in early pregnancy? We mentioned that these factors increase during pregnancy, but they do not increase upfront. They increase as pregnancy goes on. So with early pregnancy, these levels are still low. And in normal women, miscarriage affects up to 15% of all pregnancies before 12 weeks gestation. And so these patients are more liable to bleed more even than normal if they get early abortions, and need to consider provision of hemostatic support is necessary. So what to monitor during pregnancy to be on the safe side? You have to measure the VWF antigen and factor 8 procoagulant activity, at least during the first visit and at the 3rd trimester antenatally, to make sure that the labor is going to be safe. The ristocytine cofactor measurement is the best predictor of bleeding risk, and it needs to be checked once especially during the 3rd trimester, especially in women with type 2 von Willebrand's disease. Of course, you also need to check the platelet count, especially in type 2B, and the platelet count needs to be more than 50,000 antenatally. So, is there any increased incidence or increased risk of obstetric complications in these patients? In the United States, among 4,067 deliveries, there was no increase in fetal growth restriction, no increase in placental abruptio placentae, no increase in preterm birth in women with von Willebrand's disease. And the risk of postpartum hemorrhage was only 6%. However, in another study, among 506 women, 28% experienced postpartum hemorrhage and were anemic antenatally. So regular monitoring and correction of anemia and iron deficiency antenatally may be helping out with labor. So what to do with postpartum hemorrhage? Postpartum hemorrhage equals blood loss of 1,000 milliliters or more within 24 hours of birth, or any blood loss with the potential to produce hemodynamic instability. And you need to prevent postpartum hemorrhage in these cases. A high rate in women with VWD with a 3rd trimester von Willebrand factor of less than 0.5, despite prophylactic treatment with VWF concentrates, may have postpartum hemorrhage. This depends on the bleeding phenotype, previous response to treatment, obstetric risk, for example, cases of multiple pregnancies, placenta previa, should be considered. You have to consider prophylactic oxytocin, early clamping, controlled cord traction to deliver the placenta, and even prostaglandins. You have to tell the gynecologist, please avoid prolonged labor, maternal birth tract injury, inadequate surgical hemostasis during the repair or during cesarean delivery. In Egypt, they usually prefer to go for cesarean sections, elective. They do not wait for normal labor. This is not a very regular procedure, but they feel safer that way. And we try not to encourage them. Do you need to use desmopressin during pregnancy? In some cases, it has been used. It causes facial flushing, though, and it can cause hyponatremia. And it should not be given in certain cases. Of course, you need to give a test dose before, and it can cause tachyphylaxis. And in some cases of von Willebrand's disease, it wears out within 4 hours. And so you need to make sure that it can work for a long time. However, in other cases, sometimes they try to avoid during pregnancy, and sometimes they say it is not advisable to give desmopressin to children below the age of 2. So it's debatable, but if it works, then you can give it. Of course, it might be used prophylactically in postpartum hemorrhage, and because it increases the release of an endothelial store of von Willebrand factor. There's a valid treatment, primarily type 1 and in selected type 2 cases. And you need to check the baseline von Willebrand factor and factor 8. They should be higher than 0.1 if you are going to use desmopressin and you need it to work. However, it has a variable response, and the prior test dose is recommended. Be careful. It is contraindicated in cases 2B von Willebrand disease because it can exacerbate the thrombocytopenia that can accompany this type. And it is contraindicated to be used in preeclampsia because it can cause vasoconstriction. Fluid intake should be limited to 1 or 1.5 liters in 24 hours, and repeated dosing of more than 2 to 3 doses within 12 to 24 hours is contraindicated. How can you judge the desmopressin response? Well, it has to give an increase of at least 2 times the baseline of the von Willebrand factor activity level, and the response needs to be sustained, and so the levels should be more than 0.5 for at least 4 hours. Using von Willebrand factor concentrates might also be needed. These are either plasma-derived or recombinant, but in plasma-derived cases, some of the preparations contain an adequate amount of factor 8 in addition to von Willebrand factor, others do not. And of course, the recombinant does not contain any factor 8. And so if used in emergency, probably you will be needing to give some factor 8 as well. Among 121 deliveries, there was no difference in bleeding by treatment, whether the plasma-derived or the recombinant, neither by treatment nor by delivery type. So you need factor replacement, especially if you cannot use desmopressin or if it is ineffective. And when to start using it, you start using it when the mother is in active labor and as near to delivery as possible, or maybe prior to insertion of a neuroaxial catheter, because we need to avoid bleeding into the spinal cord. The peak target von Willebrand factor activity level is 1, and we need to maintain it at least above 0.5. You need to monitor the pre-treatment and the post-treatment levels of von Willebrand factor activity and factor 8, especially after delivery, especially if labor is prolonged or in cases of excessive bleeding. Plasma-derived concentrates with low factor 8 or maybe recombinant concentrates are advisable for women with a high third trimester factor 8 because we need to avoid thromboembolism later on. We're going to go back to that later. Recombinant von Willebrand factor concentrates contain no factor 8, but they have a longer half-life. In types 2B, of course, you need to look at the platelets, not just the coagulation problem. And you need the platelets above 50,000. There are spinal anesthesia UK recommendations in these cases. You can use tranexamic acid only in cases of mild von Willebrand's disease, and you can use factor concentrate for moderate or severe cases, and still the target activity would be 0.5 to 1.5. And it should be maintained above 0.5 at least 6 hours after removal of the catheter. In types 2 and 3 von Willebrand's disease, even with normal activity levels by lab, still adequate hemostasis may not be achieved. So clinically, you have to look at any bleeding problem very seriously and not just depend on lab results. Now, as soon as the patient gives labor, the von Willebrand factor goes back to normal within a few days, even in normal persons. And so we need to worry about the postpartum period, because here we are losing what we have gained during pregnancy. So we need to worry about secondary postpartum hemorrhage. And so even after delivery, you have to look at the von Willebrand factor and factor 8 levels, and these need to be maintained above 0.5 for 3 to 5 days after uncomplicated vaginal delivery and for up to 7 days following operative deliveries. In severe cases, especially type 3, von Willebrand factor concentrate may be required for a few weeks after delivery. After that, tranexamic acid may be needed as long as lochia has not stopped. Is this patient, because this is a bleeding patient, is she not a candidate for venous thromboembolism post-labor? The answer is no. Thrombotic risk assessment post-delivery needs to be weighed against the risk of bleeding. And even if in these cases, if they have an adequate concentration of von Willebrand factor and factor 8 levels, you might be considering low molecular weight heparin. Mechanical methods should be employed when factor levels are less than 0.5. So although the patient is at the risk of bleeding, still she can be at the risk of thromboembolism. Now, how about the fetus? Well, the neonates, because the mothers have von Willebrand's disease, they might have the problem too. And if you're expecting a high bleeding risk or even a mild bleeding risk, you have to be very careful with the neonate. You have to be very careful during delivery. You do not use the ventouse, you do not use the forceps. And that is why in obstetrics here in Egypt, they usually prefer the cesarean section, although it is not very, I mean, it's not natural, but still they want to be on the safe side. So be very careful, the neonates, during maneuvering with delivery. So what to do? Please go for cord blood sample for assessment of factor 8 and von Willebrand antigen and activity in the neonate. You can go as far as cranial imaging, and you can go as short-term prophylaxis with factor concentrate, especially with families that have type 3 von Willebrand's disease, especially 2 if delivery was potentially traumatic. Be careful, these neonates might bleed into the muscle. So please do not give them intramuscular injections, for example, vitamin K. And immunizations later on should be given subcutaneously. You do not use scalp veins for catheterization. Please avoid scalp vein injections. These are very liable to bleed. So in the end, it's a multidisciplinary approach. We missed one slide, but thank you very much. I'm open to questions.
Thank you very much, Prof. Mervat, for this excellent talk. I think we have some time for questions. Does anyone have any question for Prof. Mervat? Okay, I will start. We see a lot of patients who have been already seen by gynecologists and have already started on combined hormonal treatment for managing their heavy periods. How long would you want to wait until you test for actually von Willebrand antigen levels and activity? As you know, those levels can be higher in hormonal treatment.
You mean after stopping the hormonal treatment, sir?
Yes, yes.
Yes. I have to point out that many of my patients try to avoid hormonal treatment as much as possible, even if they are diagnosed as von Willebrand's disease. I don't know about Saudi Arabia, but here in Egypt, young females try to avoid contraception as much as possible, even if it is really indicated, because they are afraid that maybe it has a fertility, it is going to give them fertility disorder later on. I quite agree that maybe if they need hormonal, if they use hormonal therapy, then the antigen and activity levels might differ a little bit. I think that as you have seen, that after with pregnancy and immediately after delivery, while the hormones are going down, the female hormones are going down during pregnancy, the levels go down. So probably within 1 to 2 months, you can measure the von Willebrand factor antigen activity after stopping the hormonal therapy, just like pregnancy.
Thank you very much. Any questions for Prof. Mervat?
I have to point out, though, that I chose this subject to discuss because it's a very common subject in our region, and it is usually missed. Because these patients, they either go to the gynecologist or they present by iron deficiency anemia. They never mention menstrual bleeding as problems. They think this is the normal in their families. And so it is not their complaint. They accept heavy menstrual bleeding as the regular. So we need to point out this fact that you have a problem, and this might be in the family, and we need to do family studies. And I think von Willebrand's disease is overlooked in our region. It is definitely overlooked. And this can give us problems while labor, because the patient, we would not know that she had a problem because she never complained. What do you think? What is your experience, sir?
Very well
And
said,
the whole
Dr.
panel,
Mervat.
please.
Yeah, I cannot agree more, wallahi. Very well said. Thank you very much. Any questions? Dr. Ghazi has a question.
Thank you, Dr. Mervat, for actually exploring this important subject. I'm Ghazi Damanhouri from Jeddah.
My pleasure.
Actually, I think, as you said from the start, that von Willebrand disease is definitely underdiagnosed in our area. And really, from this, my experience, really, I think every child or people during their, teenagers, if they have this epistaxis all the time, the people, as you said, they accept it. But as a matter of fact, I think they have really, maybe if you go and investigate more, you can find this, especially type 1. And I think also the problem which we are facing, that during labor or something, for the first time, the doctor, they are surprised when they find, the patients there. So don't you think that now screening for patients really should really, I mean, for myself, by the way, anyone with epistaxis is repeated, I do really investigate. But also I believe that for OB-GYN, you see, I mean, before labor or something, really all these patients, they should be screened from the start, really, if they have history, especially we depend on history, if they have history of excess bleeding. Thank you very much.
Sir, I cannot agree more. What I suggest is just having a nice, simple questionnaire in Arabic that can be forwarded to university students, males and females of the childbearing period, and they can just answer. And anybody that has and we can have a score, not just for menstruation, but other bleeding disorders. And anyone that passes the score, I think they need to have some investigations done. And this, we can collect more than 200,000 questionnaires in around 6 months, if you have them online or something. And then we can just look at our incidence and our prevalence of von Willebrand's disease, because these are just simple tests that can have more sophisticated tests later on. So by just exclusion, we will know. And I think this can be implemented online or on WhatsApp or whatever, and very easy to do. And it can be the whole Arab region, not just one country. Very easy to do, I think.
Thank you very much, everyone. With this, I would like to conclude our panel today, discussing bleeding disorders. Thank you very much for all the speakers and co-moderators. And we will have a short break until we start with the next panel, inshallah. Thank you very much.
Okay, so it's going to be coffee break.
And all of us has to come back at exactly 3:20. We'll start exactly at 3:20 for the next session. Thank you, moderators.
I think we'll start the last session for today. We have really enjoyed the previous sessions and hoping the last one will be enjoyable. It's a pleasure to introduce our colleague, Dr. Abdurrahman Basundwa. He has his Saudi Board Internal Medicine, and after that he completed hematology fellowship in Canada, and he obtained his degree in 2019. He is also the Internal Medicine Program Director at King Fahd Armed Forces Hospital in Jeddah. He has several publications in peer-reviewed journals, and he is interested in benign and malignant hematology. Dr. Abdurrahim, he will give us an update about TTP management. Dr. Abdurrahim.
Thank you very much, Dr. Uthman. Thank you everyone for attending. I would like to thank the organizing committee for inviting me to give this talk in the update in the management of TTP. So I have few objectives that I want to achieve through my talk today. I will be talking about the definition of TTP outcomes. We will go through the update on the treatment of the TTP, and what are the newer outcomes that we have in the treatment of TTP. So it's a background and it's a take-home message. I would like to tell you by the end of this talk that TTP and other related thromboangiopathic anemia can overlap in their initial presentation. Also that TTP in the newer definitions either acquired or hereditary are characterized by the deficiency of ADAMTS 13. Sorry. And we would like to agree that the therapeutic plasma exchange along with the immunosuppressive are the main treatment for TTP, and newer treatment that came to the horizon in the treatment of TTP are changing the outcome and the definition of the outcome in the TTP. So as all of you know that the TTP is characterized by the deficiency of ADAMTS 13. This deficiency, when the ADAMTS 13 is low, either by the presence of the antibody, the ultra-large von molecule will not be cleaved by the deficient ADAMTS 13 and will cause aggregation and microthrombi. So the treatment, the main treatment has been established since 1990. Two landmark trials that were published in the same issue of New England Journal from Ottawa and from Johns Hopkins. Both of them established the era of therapeutic plasma exchange in 1991. You can see the Ottawa trial where the plasma exchange were compared to the plasma infusion. And you can see in Johns Hopkins, the trial design has been corticosteroid versus plasma exchange or corticosteroid. So you can see even at that time, there wasn't any agreeable standard of care. So there was different in management. And if you wonder why would plasma exchange would result in an outcome of less than what we see today, that's because the treatment, the diagnosis of TTP at that time wasn't well established. Most of the patients who were treated maybe on Ottawa cohort was some of them as non-TTP patient, but the definition was evolving at that time. So we have been doing plasma exchange, adding corticosteroid, rituximab as our main treatment strategies for TTP until 2017, when we have a standard terminology in the definitions of the TTP and other related microangiopathy. I mean, before that 2017 definition, a trial of standardization of the outcome and the definition was made in 2012, but it wasn't clearly outlined as in this article. So in this one, the microangiopathic hemolytic anemia along with thrombocytopenia were defined by TTB, hemolytic uremic syndrome, and other TMA with the MAHA and thrombocytopenia presentation. What we used to call an atypical HUS is now called complement-mediated HUS, and we don't call it atypical HUS anymore. TTB is characterized by the deficient ADAMTS13 of less than 10%. This is the definition of TTB, but in some cases, TTB can be diagnosed in 20% deficiency. In very rare cases that you have TTB with the ADAMTS13 more than 20%. So in this article, they gave you a lot of definition of many conditions. What we are concerned with are the very related condition are TTB, HUS, and complement-mediated HUS. TTB, as we mentioned, is the disease that is characterized by multi-organ failure and deficiency of ADAMTS13. So when you try to diagnose TTB, you have to keep in mind other differential diagnoses, including streptococcus pneumonia, copolamin deficiency, connective tissue disease, transplant, either solid or bone marrow transplant, DIC, pregnancy, HELP, drugs, others. Very interesting, the copolamin deficiency, I think, is one of the easy one to make diagnosis. We used to overlook this diagnosis, and we jump to the complement-mediated HUS before we look at this. And I think if there is no clear definition of the TTB, this would be one of the diagnoses that we can think about. So in that paper, the definition came as what to call each response type in the treatment of TTB. So we had now the clinical response and we have the clinical remission. The clinical response would mean that the patient has a platelet of more than 150 and an LDH of less than 1.5 upper normal limit. And we stopped the plasma exchange. If that clinical response is maintained for 30 days after the stopping the plasma exchange, this would be called a clinical remission. When do we call it an exacerbation? When you have a reduction in the platelet of less than 150, an increase in LDH level, and need to restart the plasma exchange within 30 days of the treatment. And if this happened after 30 days, you will call this a relapse. And then when you have a patient who you have started the plasma exchange and his platelet remain less than 50, or his LDH is still raising, and you had already 5 days of the plasma exchange, this you will call a refractory disease. And if the platelet remain less than 30, you will call it a severe refractory disease. From this talk today, we will know that there is no more refractory disease with the introduction of the newer treatment. And in the most recent definition of the TTB outcome last year, had removed the refractory disease definition from the TTB outcome. So one of the statements that was mentioned in this newer version of the International Working Group of TTB, that the use of anti-vulnerable therapy with immunomodulator and corticosteroid, it holds the promise to reduce the incidence of refractory disease. Many experts in the field think that there is no more refractory disease with the use of those newer therapy. So with this now, we had few publication we have many publications, but we have very few trial to base this recommendation. One of the latest recommendation on the treatment of the TTB came in 2020 from the ISTH guideline. So instead of going over all the recommendation, I had combined the treatment recommendation for each type of the therapy. So for the steroid, in the first event, the panel has recommended the addition of steroid to the therapeutic plasma exchange over plasma exchange alone. And this is based on a strong recommendation and very low certainty. When they say there is a strong recommendation, they mean this is a life-threatening or life-saving procedure, but a low certainty, that means there is very low evidence of the use of this treatment. So the panel wasn't able to give a recommendation in the doses of the corticosteroid in how much to use or what type to use, either prednisone or methylprednisone. In the relapse, again, the panel has recommended to add corticosteroid to therapeutic plasma exchange. And this is also a strong recommendation with very low certainty. So again, there is no much evidence. The evidence came from mainly observational study. As you have seen in the old, the study came after the Ottawa and Johns Hopkins cohort. Many had used the steroid and proved to be effective. So what type of steroid, what to use? I mean, the panel hasn't recommended. There is one article that is relatively old in 2010 that has talked about how to use the steroid. Please don't look at the response at this is, and the definition has been changing, but see that the author here used the steroid, and in refractory cases, he would use high doses of pulses of steroid. And this is one approach. I think there is no agreed definition on what to use, but this is one example of use of steroid. In the rituximab, in the first event, the panel has suggested to use therapeutic steroid with a therapeutic plasma exchange and add the rituximab. This is a conditional recommendation with very low certainty of evidence. So mean that this is not going to change the outcome of the patient too much, and also there is very few evidence. In their discussion of the rituximab recommendation, they had mentioned that the rituximab would reduce the relapse, but the relapse itself is little among patients with TTB. And I think this is need to be clarified more in the guideline, as I think the relapse is around 40%, and rituximab could have a role in the management of TTB. Again, in the relapse, the panel has suggested to addition of the rituximab if it wasn't used before. Again, the same level of recommendation. And this is maybe a newer use of rituximab, that in a patient with low plasma activity of ADAMTS13 with no sign of relapse, preemptive use of rituximab was suggested by the panel. Studies were to look at the rituximab addition were divided into either studies that look into the initial treatment addition of rituximab in the A panel, or in the regimen, or what we would call it preemptive, or in the relapse. The evidence is stronger in patient who has relapse and preemptive use compared to the initial. But if you can look at the total effect in patient with initial event, the odds ratio of the benefit is 0.4. So I think even with the lower estimate of the odds ratio 0.19, the number needed to treat is 5, which is reasonable in the treatment of in the addition to prevent one relapse. The newer treatment, the anti-volulebrand factor, caplizumab, either in the first or relapse event, the panel has suggested using the caplizumab. This is conditional recommendation in the context of the moderate evidence. And we know that this is the only treatment after the plasma exchange where we have a randomized control trial in the TTB area. And we have the two famous publications in 2016, the Titan trial, which is a phase 2 trial. And then subsequently in 2019, where we have the Hercules trial, where this has led to the approval of this treatment in the treatment of patients with TTB. As mentioned in the panel, the recommendation and the study has not differentiated between an first or relapse event, and hence the recommendation did not differentiate between the use of caplizumab in the initial or in the relapse setting. So the activity of this treatment, it works to block the antibodies that prevent the ADAMTS13. It works into the activated A1 domain that would prevent the aggregation of the platelet. So it doesn't work in the main pathophysiology of the TTB. Rather, it works into the subsequent pathophysiology where the ultra-large volulebrand would remain there, but it will not be causing thrombosis anymore. So you can imagine that the antibodies are still in the system. It needs other treatment to take it away. So the Hercules were a double-blind controlled trial. It randomly assigned 145 patients with TTB to caplizumab 10 milligram intravenously bolus, followed by 10 milligram daily subcutaneously or placebo. Of course, in addition to the therapeutic plasma exchange and other treatment. And you use this treatment for 30 days in the trial. There are different use in the real world, but I mean, we are talking now about the trial. So as I mentioned, and that was mentioned in the ICH guideline, that almost more than 50% of the patients who were in caplizumab were an initial presentation patient. So they did not differentiate between the initial or relapse. And the effect, it has an effect with a significant p-value. The primary endpoint was the time to platelet normalization, which was in the caplizumab group 2.69 versus 2.88 in patient and placebo. I will leave the interpretation for you. During the treatment with caplizumab,
3 minutes more. 3 minutes.
Okay. There is there is almost no relapse or exacerbation in patients who were in caplizumab. But when the treatment has stopped, there is more risk of relapse after the stop of the caplizumab. The main side effect is bleeding, epistaxis, and gingival bleeding, which was significant. Other side effects were not significant between the two groups, and hypocalcemia was more in the group of placebo because of more plasma exchange. So the cost of the treatment is more than 500 Saudi riyal for the 30 days. So as we mentioned, that it may cause more exacerbation after the stop of the treatment. And the newer guideline had, I mean, I will give you this at the end because of the time. Given this new mechanism that we have with the caplizumab, a newer definition has been established with the relapse and remission taking in consideration the ADAM-TS13 level during the remission. This is an example that I give in this article, where patient may have a clinical response associated with the complete response of ADAM-TS13, but sometimes there is a clinical response and a lab relapse with ADAM-TS13. Again, I reiterate my take-home message. Thank you very much.
Thank you, Dr. Rahim, for the nice talk. We'll just have a time for 2 questions. If anyone has any questions, we'll take 2 questions only. Anyone has any question? Yes, تفضل. Okay. The mic.
And I repeat, ADAM-13 level, and it's still less than 30. So do you think it's better to keep the patient on prophylactic rituximab later on, or just to extend the capsulizumab later on?
Most of the real-world experience, I mean, we have very limited experience in Saudi Arabia, but most of the experience somewhere elsewhere, they go with the clinical response. If the patient is responding clinically, regardless of the level of the ADAM-TS13, the level of ADAM-TS13 is more concerned with the addition of immunosuppressive therapy. And I think if in case that you have patient with low ADAM-TS13 with no clinical relapse, I would go with more immunosuppressive, either adding rituximab or finding other immunosuppressive to improve the ADAM-TS13 rather than adding or extending the doses of cablasizumab, if no clinical relapse.
Yes, go ahead.
Yes, thank you, Dr. Abdurrahim, for this great talk. I just have a quick question. Based on the data that you presented for cablasizumab and your experience, so when would you consider this treatment for first line? Would you consider it in any specific population?
I mean, the recommendation from the ISTH is recommending it regardless, but the real world and the most of the use has been in the more severe patient. They define this by patient who had neurological symptoms or the patient who has cardiac disease. Some people, as you said, that there is no refractory disease. If patient is refractory in the clinical response, you may also consider adding the cablasizumab.
Okay, thank you, Dr. Abdurrahim. We'll move to the second, and it's an honor to present Dr. Ahmed Barifa. Dr. Ahmed, he obtained his internal medicine degree from American and Canadian board in 2014. Then he obtained his hematology training in McMaster 2016, and this was followed by training in hematology and malignant hematology and lymphoma, and he completed his training in 2018. Currently, he's a consultant of internal medicine and hematology and malignant hematology, and an assistant professor of hematology, hematology department at King Abdulaziz University. Dr. Ahmed will talk about Castleman disease. Dr. Ahmed.
Thank you so much, Dr. Uthman and Dr. Ihab, for the introduction. And thank you for the invitation to speak about an important disease, yet very rare, but it's an important disease that have huge morbidity and also significant mortality in patients. Castleman disease. It's a rare disorder that is named by the scientist or the physician who described it first. How can I move next? Okay. So I'll start with cases, and these are real cases. Apparently, I attract a lot of Castleman disease since I came from the scholarship, and lots of cases I saw which I didn't see much when I was in training. So this is a case of 45-year-old male with unilateral cervical lymph node swelling that was slowly progressing over the last year. He had no B symptoms, and he was just bothered from the large swelling. It was a bulky swelling, more than 10 centimeter in his neck, and was always obvious, and he was complaining from the discomfort, the compression symptoms. Lymph node biopsy revealed that he has typical features of Castleman disease. The second case is for a 17-year-old female who was admitted with fever of unknown origin, fever that is going on, generalized edema, lymphadenopathy. She was quite sick. She had anasarca, she had ascites, pleural effusion, pericardial effusion, to the point that she needed a cardiac pericardial synthesis to remove the pericardial fluid because of impending tamponade. The exam showed diffuse lymphadenopathy, small volume with ascites. Investigation showed positive Coombs test with autoimmune hemolytic anemia with low hemoglobin, thrombocytopenia, renal failure that required a short period of hemodialysis. Lymph node biopsy also revealed that she has Castleman disease. The third case is for a 72-year-old male. He had waxing and waning lymphadenopathy that with recurrent fevers, repeated biopsies in different hospitals, was reactive. Most of these biopsies were done in community hospitals, in private hospitals where hematopathologists are not available, which is a very significant thing that we deal with in real life. Hematopathologists are very rare, and like well-trained hematopathologists as well. So eventually came with worsening fever to our center, and lymphadenopathy, delirium, and ascites. At that time, we repeated lymph node biopsy and revealed also Castleman disease. So 3 clinical scenarios, all behave differently, and all labeled as Castleman disease. So Castleman disease described as a group of at least 4 disorders that share a spectrum of characteristic histopathological features and have wide range of etiologies, presentation, treatments, and outcomes. We have the unicentric Castleman disease, which is clinically present like our first case. Lymph node, no B symptoms, asymptomatic except from the compression symptoms. The second is HHV8 associated multicentric Castleman disease with the presence of HHV8 virus with PCR positivity or immunohistochemical staining for HHV8. The third is idiopathic multicentric Castleman disease, and this can be divided also into 2 different types, the IMCD NOS and IMCD TAFRO, which I will talk a little bit about. The fourth, which is an additional one, most recently recognized as a different entity, is POEMS associated multicentric Castleman disease. This is from a paper that is written by Dispenzieri and Fragenbaum, who wrote most of the literature now about the most updated Castleman. Fragenbaum is, if you read his story, he had Castleman as a young kid or teenager, And he almost died from Castleman disease. And then he went into medicine and specialized in hematology. And now he is dedicated his life to Castleman disease. The unicentric, we talked about. Multicentric can be divided into POEMS-associated MCD, idiopathic MCD. Idiopathic can be divided into IMCD TAFRO, which is idiopathic multicentric Castleman with lymph node everywhere, plus having thrombocytopenia, ascites, fibrosis, renal impairment, and organomegaly. So ascites or anasarca. The IMCD and NOS, different than the TAFRO, share common things, but they don't have the bone marrow fibrosis. They don't have the thrombocytopenia. The only type of Castleman that has thrombocytopenia is the TAFRO one, the IMCD TAFRO. The rest characterized by normal platelet or thrombocytosis. The HHV-8 associated can be divided into HIV positive and HIV negative. The histopathological types are reported and often reported in the pathology reports, but they don't play a major role in the treatment and the classification guidelines. We have the hyaline vascular type, mixed variant plasma cell type, and hyperplastic germinal centers. These are pathological descriptions. Sometimes they present in the same patient simultaneously, and sometimes they present in different stages of the disease as well in the relapse setting. This is a typical lymph node appearance for Castleman disease. Germinal center proliferation with fibrosis around it, the onion skinning pattern, lollipop pattern in the lower side of the slide. The few points on the Castleman: the diagnosis is difficult, require expertise from the clinicians and from the hematopathologist, and sometimes require extended periods of investigations. When you consider Castleman, we need to talk about it more often. We need to refer to higher centers, and which will lead to a proper diagnosis. Always think of other associated autoimmune disorders. SLE and rheumatoid arthritis in particular can present with lymphadenopathy that look like Castleman and features overlap with Castleman. Malignancies, there is a report of about 100 patients. 35% of these patients had malignancies with it, hematological and non-hematological malignancies. Lymphoma is a big one. That's why with the diagnosis of Castleman, we often do PET scan to exclude the presence of lymphoma. The PET scan is useful in this setting in terms of the SUV. SUV maximum of 4 to 6 is usually with Castleman. If it's higher than this SUV, we should biopsy the higher FDG uptake lesion to exclude the coexisting lymphoma. Subclassification is very important and guide the management, which require HHV-8 testing, and this is PCR testing, not the serology testing, and LANA1 staining, which is the staining for the biopsy for the immunohistochemical staining for HHV-8. This is, again, not available everywhere, but when we suspect, we have to do it because it will alter the management. There is a notion that Castleman, or actually old name of Castleman as a benign proliferation of or lymphoproliferative disorder. It's not benign. It is a very aggressive disease sometimes, and carries a risk of mortality about 40% in the multicentric Castleman. So 5-year survival rate is worse than some malignancies. The unicentric has a good prognosis of 92% survival. Multicentric, some reports will have like 60 to 65%. Relapses are common, so patients need to be followed longitudinally and thoroughly. Just we'll go through each type and highlight some features of each type. The unicentric Castleman happen in the 4th decade most commonly, has no systemic symptoms, except sometimes will present with paraneoplastic pemphigus. So lymph node with some skin changes that unexplained. Usually the lymph node are central and has no to some rarely organomegaly. Inflammatory markers are often not raised. Anemia and thrombocytopenia or abnormal liver functions are not usually present. The IMCD NOS happen in 5th to 6th decade, has more systemic symptoms, occasional weight loss, fever, B symptoms, has lymph node peripherally overall, but often small in size, not like the unicentric Castleman. Organomegaly is present. Inflammatory markers are increased in the form of ESR, CRP, and also anemia, and often associated with thrombocytosis. In TAFRO or IMCD TAFRO, also share common features with the IMCD NOS, with more systemic symptoms and anasarca. Anasarca is very peculiar with this one, and also associated with thrombocytopenia. Poems associated Castleman happen in 5th decade with less systemic symptoms, has a lymph node peripherally and centrally. Organomegaly is a feature, and inflammatory markers are present. Anemia and thrombocytopenia are rare. HHV8 associated Castleman happen in HIV positive in the 5th decade and in HIV negative in the 7th decade. HHV8 happen because of immunocompromised status. So the HIV part it doesn't play a role in pathogenesis of the Castleman directly, but it just impair the immune system, and the HHV8 will cause the Castleman. So the main cause in this patient is the HHV8. Can be associated with Kaposi sarcoma and has peripheral and central lymph node and often small volume. Organomegaly is often associated, and it's one of the main features. Inflammatory markers, these patients are often very sick and have high inflammatory markers, and anemia, and HHV8 DNA will be detected in this patient. Just going back again to the treatment and approach for this patient, the unicentric, as we said, surgery has a benign course and risk of lymphoma is small, not as the HHV8 positive. In the NOS, the IL-6 targeted therapy is the treatment of choice. The IL-6 targeted therapy have changed the outcome of these patients in the form of monoclonal antibodies, either tocilizumab or celtuximab. Celtuximab is the FDA approved one. We have the tocilizumab more accessible for us, and we use it. The tocilizumab is a IL-6 receptor blocker, The monoclonal antibody cilitoximab is IL-6 inhibitor. So there is reports to say probably if you block the receptor or with the monoclonal antibody, maybe you have a better chance for a faster improvement. But there is no head-to-head comparison between the two. But anyway, we have in our practice the tocilizumab as the treatment of choice for IL-6 directed therapy. Rituximab can be used in the IMCD NOS as a second-line treatment, and systemic therapies in the form of steroids, in the form of other cytotoxic treatment, chemotherapy in resistant cases. The clinical course is variable. Some patients will respond very quickly. The response rate for IL-6 inhibition is probably between 60 to 70%, but the relapses are high, especially if we stop the treatment prematurely. Risk of lymphoma is there, but it's small. In terms of the TAFRO, sorry, the slide is not clear up there, but this is IMCD TAFRO. Has same as IMCD, but also calcineurin inhibitors are applied in this situation. But IL-6 directed therapy is very effective and can reverse the pathogenesis that is happening in these patients. The course is very aggressive. These patients might not recover quickly. You need to give the tocilizumab or IL-6 directed therapy frequently and monitor them. And sometimes you need to combine it with steroids and rituximab.
2 minutes more.
Okay. POEMS-associated MCD. Sorry. The slide froze. Okay. POEMS-associated MCD is treated as POEMS. Sometimes if it's localized, you just radiate the lymph node. But if it's POEMS, then you just treat as POEMS. The last one with the HHV8, the treatment can be very difficult, HHV8 positive, but rituximab is the main treatment. Remember, the HHV8 reside in the B cells, so you need a B cell directed therapy. Rituximab can be effective in these patients. Early treatment and initiation of therapy is important. About 40% of these patients will go into HLH, hemophagocytic lymphohistiocytosis. And those patients who develop HLH might not recover from it. So those are very high-risk patients. It's aggressive and can be associated with also severe autoimmune hemolytic anemia. So just quickly back to the cases. So our first case was a unicentric Castleman disease, no systemic symptoms, presenting with lymph node. So the cure was surgical excision. This patient now is being in remission for the last 3 years, doing well with no issues. The second case, this patient had a bone marrow done, showed early fibrosis. She had thrombocytopenia, so she was labeled as IMCD TAFRO. She received steroid and tocilizumab, responded very well. Within 3 days, she was off dialysis, platelet count improved, hemoglobin improved, no need for transfusion afterward. She continued on the tocilizumab for about a year and a half. And then because of COVID, tocilizumab shortage happened. And it was difficult for her to come from Umlush, which is 4 hours away from Jeddah. And then after discussion, we decided to give her a trial of rituximab for 4 weeks, weekly for 4 weeks. and improved afterward. We stopped the rituximab and the tocilizumab, and she is still in remission now, almost completing 2 years. The third case, this patient had HHV8 positive Castleman disease. He progressed quite rapidly into HLH with high ferritin, with lactic acidosis, severe respiratory failure and renal failure. He received tocilizumab and rituximab and treatment directed to the HLH, but eventually died as a complication from the HLH. So final conclusions, early diagnosis and early referral to higher center is important. Remember to exclude associated malignancies. Subclassification is important with the presence of HHV8 availability testing. And remember, this is not a benign disease. This is a very aggressive disease. It can cause mortality in significant number of patients. The treatment has advanced and should be tailored according to the patient and the classification. And remember, sharing is caring. So sharing the cases among us, which is we are doing in this meeting, reporting cases, and also national registry, which is required for all the rare diseases that we need to know about. How every center is dealing with these cases is very important, and especially with these rare disorders. And thank you.
Thank you, Dr. Ahmed, for this excellent review of Castleman disease. We'll have time for 2 questions. Yes. Can we get the mic here? Yes, it's there. Here.
Thank you for a nice presentation. I am pediatric hematology, which actually first time I hear about it. I have one child, he was presented to us at 15 months old with hypereosinophilia. Every single subspecialty in the hospital was see the child to see what the cause of hypereosinophilia with him. Anyway, we diagnosed him as idiopathic eosinophilia. We could not find any cause, but the father was not happy. He wanted another opinion. So he went to United States, which he stayed about 2 years there. Then when they want to send the patient back, which he was around 4 years, they said, they sent for me email that your patient diagnosed as Castleman disease, and we treat him, they give him, I remember every single chemotherapy, they give rituximab, vincristine, etoposide, as well cyclophosphamide, and we are going to send him back to you with cyclophosphamide. Then because I sent him for hypereosinophilia, then said, by the way, for the hypereosinophilia, it's because stranguloidosis was found in the stool, and we treat him. So when he came back to me, he was around 4 years old. I was, as your plan, that wean him cyclophosphamide for 6 months. Then his eosinophilia is coming back up. I repeat for stranguloidosis, and this is negative. Anyway, this patient, he responded very dramatically for steroid. Even he had only minimal dose, so control his eosinophilia. So for Castleman, first time I hear about it, I go to read about it. I found it's in elderly. There is no relation between eosinophilia and that disease, and his CBC completely normal, the platelet DCT negative, everything. Anyway, he's now with us more than 6 years. He's still, his eosinophilia is an issue, but he's in very minimal dose, which is about 2.5 alternate day. If we stop it, or he will have lymphadenopathy if with high eosinophilia, but he was controlled. So as you said now, you scared me that Castleman is very bad disease, and he can progress. So he's stable, alhamdulillah. But still, I did, because genetic study, even we said it 2 times, for him, there is nothing. So I don't know how they convince it's Castleman that this child. So I don't know if you encounter such cases like this.
Very interesting case. I'm an adult hematologist, so I don't know the details of the Castleman in pediatric, but it often requires a lymph node biopsy, which is sometimes difficult to interpret because there is huge overlap between other benign disorders or autoimmune disorders that can present like Castleman as well. As far as I know, eosinophilia is not associated with Castleman disease, but how they reach to the diagnosis is important to know, like if they had a lymph node biopsy was convincing, if the bone marrow showed any other features.
This is what they said according to their biopsy, but we did biopsy here, which was not suggestive. But anyway, now the agreement that our hematopathologist, I don't know if he is here, we said if he had lymphadenopathy, we are going to do it. Thanks God, now 6 years he is, but still he has steroid, he has eosinophil. If we stop the steroid or we net off,
eosinophil will go up.
Eosinophil is gone with lymphadenopathy, but once he controlled, this everything is fine. It's interesting,
Yeah, very interesting case, but I think the eosinophil should be investigated as a different thing than the Castleman. For tocilizumab, if they use tocilizumab, then the recommendation is to continue lifelong on tocilizumab, except if they did something else. It sounds like they used rituximab-based treatment with chemotherapy, which is used in severe cases, a combination of like R-CHOP or the rituximab etoposide, or rituximab vincristine. So these treatment options can be given for resistant cases for Castleman.
Thank you very much, Dr. Ahmed, again, and we'll proceed to the next speaker.
It's my pleasure to introduce the next speaker, Dr. Ail Omar Yahya, who is a graduate of King Khalid University in Abha. He had a board internal medicine, Saudi board for internal medicine in Abha. He had extensive hematology training in Ottawa, hematology fellowship, malignant hematology fellowship, and bone marrow transplant fellowship. And he has recently returned from Canada and is working as a consultant malignant hematology stem cell transplant at King Khalid University, Abha. He's going to present to us ruxolitinib in non-JAK2 mutated MPN.
السلام عليكم جميعا. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء. Thank you for having me in this annual big conference. It is a pleasure really to be here. So I'm going to talk about one of the rare topics, which is the ruxolitinib in non-JAK2 mutated MPN. So as we know these days, the ruxolitinib is a cornerstone for the management of myeloproliferative neoplasm, though it did not change the landscape of myeloproliferative neoplasm as the other TKI did in the CML. Starting with so disclosure is none. Brief introduction. So myeloproliferative neoplasm arises when the polyclonal proliferation of myeloid cells in normal health is replaced by abnormal monoclonal proliferation, resulting in overproduction of the following: red blood cell end up with polycythemia, platelets end up with essential thrombocythemia, bone marrow fibrosis end up with primary myelofibrosis. Common in older adults, all share the risk of thrombosis and hemorrhagic pathologies. The main clinical challenge including increase the risk of leukemic transformation and also transformation to the secondary myelofibrosis, either from BP or ET. Couple slides. So my topic is JAK2 in negative, ruxolitinib in negative JAK2. So just trying to give you a couple slides about the pathophysiology so we can realize how it's got approved used in JAK negative. or reduce in MBN regardless of the JAK status. So as you can see, under normal circumstances, hormonal signaling of erythropoietin, thrombopoietin agonist, colony stimulating factor, other cytokine drive, enhance the production of erythrocyte, platelets, granulocyte through the receptor of the JAK signaling. So so as you can see, like, I mean, through these erythropoietin or EBO stimulate the JAK, then the JAK stimulating two pathway, either JAK stat or JAK relative pathway, which including MABK, AKT, and B13K. So what's happening in the myeloproliferative neoplasm or in BCR-ABL negative MBN, they are all mostly share exclusively mutual JAK2 pathway activation, which can happen in the context of MBL mutation, carotenoid mutation, or even JAK2 mutation, and lead to the activation of the JAK2 signaling pathway, then end up with cell proliferation, and lead to the survival of the cell and differentiation, and end up to these kind of just to mention that dysregulation of the JAK stat signaling pathway has been associated with the several cancers and increased proliferation in the survival of malignancy. And from this, I mean, explanation, we know that MBN, they associated with secondary cancer. So I'm showing you that to tell you like how the pathogenesis is deep and not well understood. Other more cartoon to show you, like if you can see in E, D, and C, there is no mutation in the JAK2. There is other mutation, other driver mutation, and still we activated the JAK stat signaling. I brought this chart which representing the relative proportion of the driver mutation and additional mutation detected in the polycythemia, essential thrombocythemia, and myelofibrosis. On the right side, the genes mutation, which is non-driver mutation, these genes may occur concurrently with the clones or with the subclones in the absence of the driver mutation. Why I'm bringing this? Just telling you that the pathogenesis is not yet well understood, despite the advances in the last decade. Understanding the impact of this genomic complexity and clonal evolution on MBN phenotype, pathogenesis, prognosis, and response to the JAK is critical to improving our therapeutic approach in the future. So ruxolitinib. So as we know, ruxolitinib is a selective inhibitor of the JAK1 and JAK2 that resulting in inhibition of the JAK stat signaling pathway, regardless of the status of the JAK mutation. As we know, it's got approved for myelofibrosis for those with splenomegaly or disease-associated symptom in intermediate and high risk. Also got approved in polycythemia vera for those who's not tolerating hydroxyurea or other cytoreductive agent. What I'm going to focusing in two topics: primary myelofibrosis, secondary myelofibrosis with the JAK2 negative and essential thrombocythemia. I spare the polycythemia vera as by definition we need the JAK2 to be positive. According to the COMFORT-1 study, JAK2 is present in approximately 50% of the patient with primary myelofibrosis. Other mechanism of direct or indirect activation of the interstitial JAK signaling stacked pathway are known, which suggesting that dysregulation of this pathway is a central pathogenic component in myelofibrosis, regardless of the mutation status. So ruxolitinib result in durable reduction in splenomegaly and improvement in the myelofibrosis-related symptom, regardless of their status with the respect of the JAK mutation. I'm just focusing in the data about the JAK2. So according to the COMFORT-1 study, here a post hoc analysis of the subgroup, and in this post hoc analysis, it showed that the mean change in the spleen volume among patients with the JAK mutation were 34% versus 8% in the placebo group. The corresponding change among patients without the JAK mutation were 23 versus 8 in placebo. Again, in the same post hoc analysis, they assessed the change in the total symptom scores, and the change in the total symptom score among patients with the JAK mutation were 52 improvement in the JAK positive versus worsening 42 on those placebo. Again, there is significant also improvement for those who have JAK negative mutation versus placebo versus 37% worsening. According Comfort 2 study, which is a randomized phase 3 trial that compared ruxolitinib versus the best available therapy in primary myelofibrosis and secondary myelofibrosis. I just put snapshot for the baseline characteristic to show you that we have a good number of negative JAK2 in the study. And again, in the post hoc analysis, reduction in the spleen volume with ruxolitinib were seen across all patient subgroup regarding the gender, the phenotype, and the risk of myelofibrosis, also the JAK stat mutation. And the rate of reduction in the spleen volume in the JAK positive subgroup were 33 versus 0. And also it seemed working also in the JAK negative subgroup. So we have 14% versus 0, though it seemed that patient with the JAK2, they're responding better than patient with the JAK negative. So next is the essential thrombocythemia. So what we have in essential thrombocythemia with those who have JAK negative. So according to the MAGIC study, a point mutation on exon 14 or JAK2 in exon 14 found in around 50% of ET. The remaining, they have either carotocylin, MBL, or there is a small percentage who have a triple negative. As we know, the standard of care these days for high risk ET, low dose aspirin with hydroxyurea as first line of therapy. Therapeutic approach addresses the risk of thrombosis and hemorrhage without increasing transformation into post-essential post-ET myelofibrosis or acute myeloid leukemia. So MAGIC study compared RUX versus best available therapy. They involved 58 patients were randomized to the RUX. And the primary outcome was achievement of complete CR within 1 year. And they defined the CR based on European leukemia criteria, where they want the platelets to be less than 400 and the leukocyte. And again, I brought you the characteristic of the patient just to show you only 50% who have the JAK positive and the rest of distributed between other mutation or none. The result, there was no evidence based on the MAGIC study. There was no evidence of improvement in complete response within 1 year. At 2 years, the rate of thrombosis, hemorrhage, and transformation were not significantly different in those group. In contrast to the MD Anderson study, so a study where they include 39 patients with essential thrombocythemia were enrolled, including 26 in the dose finding phase and 13 in the expansion phase. So RUX treatment was associated with improvement in ET-related symptoms, as well as better and durable control of the following platelets, leukocyte, and hemoglobin count. This was for both those who have JAK mutation or without, and the reduction of JAK2 allele burden was also noted. However, we have to mention that in MAGIC study, the previous line of therapy, it wasn't only the hydroxyurea as what happened in the MD Anderson study. They use other cytoreductive agent, anaglyride, they use even busulfan. Some of patients, they get busulfan and interferon. So to end up with that, there is no clear evidence in essential thrombocythemia to use the RUX for those who intolerant. So upon the data literature review through the PubMed and other software by using the following keywords, we end up with the following paper, and I'm just trying to find something outside of the clinical trial. Here a paper by Breccia, which is a retrospective multi-center analysis outside of the clinical trial that done by the Lazio cooperative group. Aim of the study is to report the safety and the efficacy of ruxolitinib in 98 patients affected by myelofibrosis treated outside of the clinical trial and collected and treated for the Philadelphia negative MBN. 45 overall, I think they have overall 40 patients receive hydroxyurea as previous line, as first line, 30 patients receive other cytoreductive agent, and there were 28 who received ruxolitinib as first line of therapy. So 50% of them were primary myelofibrosis, and the 50 secondary myelofibrosis. Just to mention that 70% were JAK mutated, so we have around 30% who have JAK negative. So at 48 week, as you can see in the right side, the response according IWG criteria, at 48 weeks, 52 of the patients obtained clinical benefits. 7 of them, they went in CR, 10 BR, 28% spleen response. Overall, 66% of patients had disappearance of the baseline symptoms. At first event, as usual, mainly the hematological toxicity, mainly the anemia, thrombocytopenia, plus fluid retention, diarrhea, abdominal pain. At 1 year, after 1 year of 72 evaluable patients, 52 achieve and maintain a clinical benefit. And after median follow-up of 16 months from the start of ruxolitinib, median daily dose decreased to the 10 milligram BID, and 21 of them, they discontinue the drugs. So the result of this retrospective multicenter analysis outside of the clinical trial confirmed the efficacy of ruxolitinib regardless of the JAK status. Again, here a study, this other paper by Fanucci, which is a pooled analysis of the both COMFORT-1 and COMFORT-2, and they're trying to assess the overall survival. And overall survival. So these pooled study were evaluated for the treatment and the effect on overall survival in these two biovital with prolonged follow-up in intent to treat analysis, as well as an analysis accounting for the crossover of the patient in the control arm. As we know, in the COMFORT-2, there is a good number of patients who cross over to the RUX group. So patients who were originally randomized to the RUX survive longer than without change in spleen volume and refer and overall survival advantages. However, to mind you that neither COMFORT-1 or COMFORT-2 were designed to assess the overall survival. And I think it's not easy to assess the overall survival in MBN, because we need years to assess the overall survival. And so what is trying to looking why offer survival, there is benefit in the ruxolitinib group regardless of the status. And it seemed because of the spleen reduction volume is the main factor, also decrease the inflammation related with the use of ruxolitinib, and also the consistent symptom. This is end up with the change in the overall survival, and even there is which led to the reduction in the death by 30% in the RUX group. In this paper is a good review. So what I conclude from this paper, the effect of ruxolitinib on bone marrow fibrosis. So RUX was found to decrease serum cytokines level, reversing the constitutional symptoms, therapy leading to the clinical improvement. So these cytokines are produced by the mutated and non-mutated hematopoietic stem cell, leading to the progressive bone marrow fibrosis. So in COMFORT-2 study, the bone marrow fibrosis was reduced in 16% of the MF, had improved after median duration of treatment of 2.2 years. So I'm just brought this to telling you that we don't need, it's not only if the JAK positive, is not only the RUX work by the JAK positive or negative, but also it's work in different mechanism by inhibition of the cytokines, which has impact on the bone marrow fibrosis. Again, all of these, the study wasn't designed to assess for the bone marrow fibrosis.
4 minutes.
Other two paper, and I would summarize just briefly that seeing that testing for a 6-cell H2 IDH1 for those who have negative JAK2 and color and MBL sound a reasonable approach. And why that? It seems that the response, the spleen response for ruxolitinib in those who have JAK negative and have non-driver mutation, specifically a 6L1, DNMT3, EZH2, or complex more than 3 non-driver mutation, substantially have low response for the spleen, and then they have less overall survival. So to ramp up with this summary, so ruxolitinib is an oral JAK1, JAK2 inhibition resulting in inhibition of the JAK-STAT signaling pathway. Ruxolitinib is recommended and approved for intermediate 2, is not only for one, intermediate 2 and high risk MF regardless of the JAK-STAT mutation. In case of intermediate 1, I mean, we know comfort study, they involve only the intermediate 2. However, there is a good body, a good body data that's supporting the use of ruxolitinib in intermediate 1, specifically for those who have splenomegaly more than 5 centimeter. And this is also supported by two study, JUMP study and UK robust study for mainly myelofibrosis. I didn't talk about them just because of the time. And also I couldn't find the percentage of the JAK mutation on those 2 studies. Subsequently, also the ruxolitinib was approved for BP. As we know, it seems there is no clear evidence of any benefits in essential thrombocythemia. So ruxolitinib is very helpful in splenomegaly, in the inquisition symptoms, and also in the survival. But again, there is no anti-clone activity. It doesn't kill the JAK cells. So it doesn't change the landscape of the disease as the TKI did in the CML. And I think we need to work, we need a lot of work on MBN. So despite of this, still there's benefit overall survival. We cannot deny that. And this is also reported by either the trial or outside of the trial. I didn't talk about the side effect, but I can briefly. The main side effect is the hematologic toxicity, mainly anemia, and the most common cause of the discontinuation is mainly the anemia. However, there is different approach to overcome this side effect. Just to mention that when you compare ruxolitinib with the other JAK inhibitor, for us, it seems we have good experience with ruxolitinib, and there is no significant GI toxicity or Wernicke encephalopathy that's happening with the other JAK inhibition, other JAK inhibitors. And just to mention that with the long-term use of JAK, of ruxolitinib, there is high risk for opportunistic infection, and in some center they have their own approach by using shingles vaccine inactivated or Shingrix, or using a cyclophosphamide prophylaxis. They also assessing for hepatitis B and C and HIV before proceeding with ruxolitinib. Lipid profile monitoring is depend from center to center. There is no clear data, but it seems all the side effects are acceptable. Regarding the secondary cancer, the only one established is non-melanoma skin cancer, though it is rare. For non-Hodgkin lymphoma, there is no clear evidence that ruxolitinib can lead to or result in NHL or non-Hodgkin lymphoma. However, MBN by itself, they have risk for secondary cancer, and this is reported in many retrospective study. So I think by end of summary, I conclude my presentation, and thank you for your attention.
Thank you very much.
And I think I lost the thank you slide. There is thank you slide. Just
we are running a bit late on this session. Maybe we'll allow only one question if it is a very burning question. Yes.
Ruxolitinib mainly because of splenomegaly, and as you know, only less than a third of patients will respond to ruxolitinib in reducing significantly the spleen size. Now, in those whom you prescribe this, and when do you stop it? If you will stop it, despite the fact that we know for a fact that ruxolitinib ameliorates the constitutional symptoms significantly and improves the quality of life of patients. Would you continue because of that, or once you have reached to a conclusion that it did not shrink the spleen, you have done your ultrasounds and spleen size is more or less the same, as almost 70% of the patients will have this outcome?
So the ruxolitinib is not curable. We know we're not cure. We're not touching the cure or the modifying the disease of nature. What I would say, if after 6 months there is no response from the splenomegaly wise, then I mean we can balance. If there is a good effect on the consistent symptoms, I would continue if there is no side effect of that. But if there is no significant change in the consistent symptoms and the spleen not shrunk, so there is no point to continue. I mean, all the study wasn't designed to improve the fibrosis, for example, or the overall survival. We don't have evidence for that. So I wouldn't continue. However, if they respond well, shall we continue indefinitely? This may be the question here. And the answer is depend. What is the next therapy for myelofibrosis? Is it the transplant? Is the patient eligible for transplant? Is he fit for the transplant? Then I would continue until I get him to the transplant. And the idea behind that, there is no big evidence, but there is good data that's saying that if the disease was well controlled from the spleen perspective, from the constitutional symptom, which is going to lead to the good performance, then the patient will did well in the transplant. And we can even use it until 1 day before the transplant. I hope this answered your question, if I understand it well.
Thank you very much.
You're welcome.
Thank you, Dr. Ail, for this nice presentation. So I have one announcement. We have an evening satellite symposium in hall number 1 at 8 p.m. tonight. 2 sessions, one sponsored by Astellas on future leaps in the management of FLT3 AML by Professor Naval Daver from MD Anderson. The second session is sponsored by BMS Satellite Symposium, Beta Thalassemia, Disease Burden and Complications by Abdullah Al-Zaid from Qatif Central Hospital. And the next session is a satellite symposium on PNH, and the chairman would be Dr. Ayman Hijazi.
Thank you, Dr. Ihab. Hi, Dr. Austin. Do you hear me?
I can hear you very well. Thank you.
Dr. Austin, you seem to be busy.
No, I can hear you very well. Thank you.
Well, our next talk is going to be about PNH, paroxysmal nocturnal hemoglobinuria, which is, as everybody knows, is quite a rare disease, but is of great interest to many. And one of those is Dr. Austin. So Dr. Austin is a consultant hematologist at King's College Hospital in UK. He has interest in multiple diseases, including acute myeloid leukemia, aplastic anemia, MDS, and of major interest is PNH. Dr. Austin is also the lead of King's PNH Center, which is one of the 2 NHS England commissioned highly specialized services for PNH. And he will talk to us about PNH. Dr. Austin, you can hear me, right?
Yes, I can hear you very well. Can
Okay,
you hear me?
Go ahead.
You can hear me. Okay.
Yes.
Thank
go
you.
Ahead. The screen is yours.
Yeah. Thank you for those kind introduction and those kind words as well. So, and thanks for the very kind invite. Apologies, I can't be there on person, but one day definitely hope to see you all in person. But thank you so much for this kind invite. So hope I'll try to talk to you about PNH in the next 20 minutes, mainly focusing on therapeutic advances, but also around some of the basic aspects of PNH, which is still fascinates me to this date. So
we have 20 minutes, by the way.
Yes, I will finish in 20 minutes. Thank you. So, when you talk about PNH, we know there is always a clinical triad of PNH where this is associated with chronic hemolytic anemia with paroxysms, and this is a complement-mediated hemolysis. Patients have significant propensity to develop thrombosis, mostly in unusual sites, but also commonly DVTs and PEs are also not uncommon, and this significant association with an underlying marrow failure, be it aplastic anemia predominantly, or also MDS in about 80 to 90% of the patients. And it's a disease.
Dr. Austin, sorry, we see all the slides. We don't see the main slide. Can you please put it in the presentation mode?
It is on the presentation mode. Can you see the slides moving?
We can see the slide sorter. I mean, all the slides together.
Okay.
Can you stop sharing and reshare again?
Yeah, I could do that. Thank you. Apologies. Is that any better?
Yes, definitely. Now we can see the main slide,
Okay,
which is
thank you.
diagnosis. Yes. Okay,
Thank
go
you.
ahead.
Apologies for that. So the previous slide I was showing was around the basis of PNH and why this unusual triad of three things and such a rare disease as well. Still, we think it's less than 1 per million with incidence and prevalence higher because we are able to treat these patients and keep them alive. So and this underpins the screening. So as hematologists, as we all know that in the context of patients presenting with marrow failure, unusual or unexplained thrombosis, or in the context of hemolysis, predominantly Coombs negative, we will want to check for the PNH clone. And various algorithms have been developed in the context of trying to understand what group of patients would be screened for PNH. So the one thing I always say about PNH is, although it's a rare disease and it's an ultra orphan disease, the diagnostic test as compared to other rare diseases is quite sensitive and specific. So even if it crosses in the back of the mind that you need to do a PNH clone, I would do it. And it's an easy test to be done on a peripheral blood using a high sensitivity flow cytometry. And if you're not able to detect the PNH clones, then we know that this is not PNH and move on. But it's important to test for PNH in variable scenarios as indicated. Simple things like if you have a low haptoglobulin unexplained or an unexplained high LDH or a reticulocytosis with mild cytopenias or an unprovoked unusual sites of thrombosis, those are things which you would be careful and try to ascertain PNH. And we know it's a disease which can be challenging to diagnose, where various scenarios can be seen, not just thrombosis, but also other features in the diagnosis of this disease, including renal dysfunction, which can be seen in about a third of the PNH patients at the onset of diagnosis. So what is PNH? We all know that normal blood cells have got GPI anchors, and GPI anchors are important to bind the complement regulatory proteins. And this GPI anchor is encoded by a gene which is called PIGA gene. And that is where the defect is in PNH, acquired somatic mutation in the PIGA gene, leading on to lack of GPI anchor proteins, and thereby the complement regulatory proteins are not there on the surface of the cells, predominantly being CD55 and 59, which protects the cells from complement dysregulation. And when PNH patients present, they do not have the complement regulatory proteins. And complement system is a part of your innate immune system, which is always active in your body. So whenever there is complement activation, which is there at a low level for everybody at any time point, but you have complement regulatory proteins to protect them. But in the context of PNH, you have complement activation and have GPI anchor negative cells, and leads on to hemolysis. And importantly, symptoms related to that, which is the liberation of free hemoglobin, nitric oxide depletion, leading on to the catastrophic symptoms associated with PNH. And not only that, as I showed you before, there is a big association with the underlying bone marrow failure, and there is never a static PNH disease, where there is always an interplay between the underlying bone marrow failure and the PNH, leading on to varying degrees of hemolysis and cytopenia. And we looked at our King's database of a large number of patients over a period of many years, for nearly 20 years, to look at the prevalence of PNH. And we were able to, even in the context of MDS, we were able to pick up in about 20% of MDS, predominantly low risk, we were able to pick up the PNH clones. And not surprisingly in aplastic anemia cases as well, where there was where the PNH clone is seen in around 60% of the cases as well. And this is associated with a better prognosis and survival, both in the context of MDS and aplastic anemia. The dark line is the PNH negatives in the context of MDS and AAA. Dotted lines is in the context of PNH positive, having a better prognosis. And this classification, although it's nearly 16 years old, does have a role, at least in segregating this group of people into 3 different classifications, i.e. subclinical, classical, or PNH in the context of an associated bone marrow failure. And we know due to complement activation, this is a disease which can be progressive because it leads on to vasoconstriction, hypertension, thrombus formation, and loads of things to do with platelet activation, aggregation, and consumption, and other mechanisms which lead on to thrombosis, including endothelial activation and injury. And some of the symptoms associated with hemolysis can be quite subtle and can be something which can be seen in any patient presenting to hematological clinic or any clinic. But unfortunately, what we are trying to prevent is the catastrophic end organ damage sustained by these patients over a period of time. So when it comes to treatment of PNH, this is how I look at it and to see what patients could benefit from. So why do patients with PNH need treatment? And that, I think, hopefully I've shown you that this is to prevent the end organ damage, to prevent the mortality and morbidity predominantly related to thrombosis, but also other organ damage, and also to improve the quality of life. And it's a question of who needs and when do they need treatment. What is the appropriate first line of therapy? I'll probably touch upon tiny bit about anticoagulation versus anticomplement therapy, because this is all historical data, and transplant versus not, which is also pertinent in countries where there is no availability of C5 inhibitor. And it's a question of when do you start a C5 inhibitor, and how do you monitor these group of patients? And this is taking a step backward on the historical treatments for PNH, which we had for many, many years prior to the advent of anticomplement therapy. And some of them which are highlighted in yellow, we still use it. Predominantly the primary prophylaxis in patients who do not have significant hemolysis, who do not need a C5 inhibitor therapy, whether we would use warfarin, because there is no data for using of direct anticoagulants and the novel anticoagulants to prevent thrombosis. But a word of caution is the negative trial from antiphospholipid syndrome, where warfarin was proven to be better than the direct anticoagulants, would make you worry about not switching them to direct anticoagulants. So in the next 12 minutes or so, I'll try to show you what treatments have gone through in the last 16 years since the first clinical trial of using eculizumab, and where do we stand, at least in the context of approved treatments, which would be both eculizumab and ravulizumab, which is the long-acting complement inhibitor. So eculizumab was never made for PNH, this was a serendipitous discovery. Because it was potentially tried in the context of other connective tissue diseases, but we know eculizumab binds with a very good affinity to C5, blocks the terminal complement cascade, and does preserve the proximal functions of it. And as I said, we've used eculizumab for nearly 16 years or nearly 19 years, because the first patient was started in the pilot study was back in 2002. And interestingly, that patient is still with us at King's, and also the other patient in Leeds as well. So we know clinically that reduces hemolysis, as we've seen in a number of clinical trials over a period of time. And these are some of the indications for treatment which we use in King's. Transfusion dependent due to PNH, it's easy. If they're independent of transfusions, they have to have a thrombosis related to PNH, any complications related to hemolysis like pulmonary hypertension or renal failure, pregnancy, which is an important aspect, because historically we knew pregnancy was sort of a no-no in PNH, but we know we use eculizumab quite safely during pregnancy, although it's not an approved indication, and when they have hemolysis with any of those symptoms. And very rarely, when exceptional cases, we will talk between the two centers and agree for treatment of it. And there is no question about the efficacy of eculizumab in PNH, and the clinical trials have shown that it reduces hemolysis, abolishes or abrogates the needs of transfusions. Very, very good component for preventing the thrombosis and improvement of fatigue and also the renal complications and survival as well. So I've not updated the survival slide, but we have done one recently in the last 6 months, but it shows the same compared to the historical data from Peter Hillman, which was published 16 years back, showing that about 30% of PNH patients died within 5 years of diagnosis, which is not the case now, which seems to be similar to the age and gender match population. But what are the issues we see during eculizumab? Because we know quite a lot of patients derive significant benefit from it and stopping the thrombosis and improving quality of life. But there is a group of patients who still, although transfusion independent, might remain anemic, as shown in this two data, one from Leeds, our other center, and one published by Antonio Risitano, showing that despite eculizumab, there are patients who remain anemic. And there are various reasons why these patients could be anemic, predominantly related to their underlying bone marrow failure or simple things like hematinic deficiency or iron overload or inadequate erythropoietin, or they could have an elevated reticulocyte count. And this could be due to two reasons, predominantly. One, persistent intravascular hemolysis or significant extravascular hemolysis. And this is a patient from one of the pivotal trials showing that during the day 12, day 13, day 14 of eculizumab, these patients do have sometimes start getting high LDH symptoms and or dark urine. So at least in UK, around 20% of patients are on higher doses of eculizumab, which obviously is not a licensed dose, but are able to control their breakthrough hemolysis. The second phenomenon, which is quite fascinating and which I'll touch upon, is something called extravascular hemolysis. So we know eculizumab binds to C5, blocks the terminal complement pathway. Very rare to have this mutated C5, which is resistant to eculizumab, stops the binding. But predominantly what happens is, although you're blocking the terminal complement cascade, the proximal loop is undergoing amplification, leading on to deposition of degraded C3d fragments on the surface of the PNH red cells. And that is detected by flow cytometry, but has to be taken up by the reticuloendothelial system as an extravascular or hemolysis, i.e. they will get into the reticuloendothelial system to be hemolyzed. So there are various reasons why there could be reasons why you want to have a better treatment or a step up to eculizumab in the context. And that's one of the reasons I put this slide. Why do we need? Because we need a better control of terminal complement, prevention of extravascular hemolysis, and ability to work in all patient groups, and also better modalities of delivery, because we should not forget this is a lifelong or a long-term treatment. So getting it every 2 weekly is not good for some of the patients, and also cost and availability as well, because we know that although eculizumab is approved in a number of countries, access is difficult because of the other issues associated with it. So what can we do for better treatments of with eculizumab, and what can we target? So this is the same complement loop which we are seeing in the context of eculizumab. So you could see that ravulizumab, which is a long-acting C5 inhibitor, is a high affinity anti-C5 monoclonal antibody, which is derived from eculizumab through the targeted engineering. And what it does is it enhances the FC receptor recycling so that it binds to C5 easily, but is also be able to recycle back into the cell surface because of the pH differences, because of the modification of eculizumab. Just 4 amino acid modifications which were done both in the complement determinant region as well, thereby lasts in the patient's system for a longer period of time. So these are the couple of pivotal trials which we were fortunate to be involved with, nearly 450 patients, both in the context of patients who PNH patients who are complement inhibitor naive, i.e. who never had any complement inhibition or eculizumab, or also in the patients who were stable on eculizumab over a period of time, and they were able to be switched to ravulizumab. And this is how it was given. So it was given as a loading dose on day 1, and then day 15, and after that every 8 weekly. So essentially a new patient will have 7 infusions of eculizumab rather than 29 in ravulizumab rather than 29 infusions of eculizumab in a year, and essentially showing that in the context of the patients who did not have prior complement inhibitor treatment, it showed that it met the primary endpoint, i.e. non-inferiority. So it was similar to eculizumab in the primary endpoint, and also in all the secondary endpoints, including transfusion avoidance, LDH normalization, breakthrough hemolysis, and hemoglobin stabilization. And similarly, the PNH 302 trial, which compared patients who previously had eculizumab, showed a similar efficacy data as well in both in the primary and the co-primary endpoints. One of the important things I always show is about this breakthrough hemolysis. So this seems to be totally, at least the pharmacokinetic breakthrough hemolysis seems to be totally avoided with ravulizumab. So as you can see, there is no fluctuation of the C5 levels like what you're seeing here with eculizumab, thereby showing that if ravulizumab has got a very, very tight control of the C5, inhibiting sustained inhibition of it. So none of the patients on the ravulizumab had breakthrough hemolysis related to inadequate dosing of the drug as well. And but there are some pharmacodynamic breakthroughs, which we will talk about in a second. But more important for me is the patient perspective. So patients totally loved ravulizumab when it compared to eculizumab because they were only getting 6 or 7 infusions in a year. So from all aspects, frequency, ability to plan their lives, quality of life, effectiveness of the medication, controlling fatigue, side effects, they were able to prefer eculizumab over ravulizumab. But more importantly was the frequency of the infusions and ability to have a better quality of life as well. So what I would say when you commence a C5 inhibitor is I'll always check for the LDH to see if it is controlled or not. Then you would want to look at the LDH control. Then if the LDH is very well controlled, you will continue the treatment. But if the LDH is not controlled, you will try to look at other modalities to say whether they're adequately complement inhibited, and look at the hemoglobin to see if they have a symptomatic anemia, and then look at their retic count to see if they have a low or normal. Then look at the pathway of why is the retic count low, or if the retic count is elevated, there could be various reasons why these patients could continue to be anemic and symptomatic, and to deal with it. So the question always is, what are the new agents which are potentially in the come to the market in clinical trials? In my next 2 or 3 slides, so I'll take another 2 to 3 minutes of your time. So one of the trials which was published in NHM was comparing this C3 blocker Pegasus or pegcetacoplan compared with eculizumab with the difference in the hemoglobin. So again, approved by FDA, but also approved by the NICE, improving the hemoglobin. The second agent which is going through clinical trials is this oral factor B inhibitor called iptacopan, and showing that on addition to eculizumab, it was able to control the LDH. Most patients were able to be transfusion independent. This is the number of transfusions they received prior to the study, and since coming on to the study, none of these 10 patients received blood transfusions, and most, if not all, patients are now being able to stop. It's given twice daily, and now phase 3 trials are ongoing. So this is a study which we recently published in Blood, looking at another factor D inhibitor called danicopan. Similarly, in 10 patients, except 1 patient, all the patients were able to become transfusion independent. But this is in addition to eculizumab or ravulizumab in the new trials, which is being tested, to ability to control the hemolysis when added to distal complement inhibitors. And there are a number of agents. These are some of the ones which I'm showing in clinic, which are in clinical trials or completed clinical trials, proximal distal terminal complement inhibitors, inhibitors of the broad C3 pathway, which we talked about, pegcetacoplan, or the specific pathways, and some of the agents I talked about as well. And you might have recently seen the approval of the proximal C1 serine protease inhibitors, sutimlimab, for cold hemagglutinin disease, but never to forget about biosimilars, because they would have a role as well. Just a last point about COVID and AA and PNH. Again, we advise all patients should have vaccination. We have reported worsening of aplastic anemia in the context of SARS-CoV-2 infection. And there have been some reports, to my knowledge, which has been reported of vaccine-induced AA as well. But in the context of PNH, I think that we've noticed some worsening hemolysis, but definitely vaccination should be suggested. So if you look at algorithm, so with the subclinical PNH, you don't need treatment, you focus on the bone marrow failure. PNH with bone marrow failure, you might want to treat both of them. But in the context of classical PNH, you treat them with anti-complement therapy. So some of the algorithms which you would do is classic PNH, you treat them with eculizumab or ravulizumab, preferably ravulizumab at the moment because it's approved. If you have a hemolytic component or aplasia component, then you decide based on the disease activity. Sometimes you can do immunosuppression followed by C5 inhibition, or sometimes we might treat them both with immunosuppression and complement inhibition. But in the context of aplasia, you do it differently. So this is the two centers which treat. So till date, we have treated around 550 patients with eculizumab in the UK before switching them to ravulizumab to see whether they will be able to control the hemolysis in the same perspective as well. But to summarize and conclude, what I would say is it's one of the vicious thrombophilic states in medicine. I did not say it. Somebody more wiser and cleverer said it, Professor Lucia Lisato. Eculizumab was never made for PNH, nor was ravulizumab, but it has significantly reduces the complication. So as I told, till March 2021, we had treated around 490 patients in the service, significant impact on quality of life and organ damage. So there are still some unmet needs, and ravulizumab seems to overcome some of the issues with eculizumab, predominantly patient convenience and no pharmacokinetic breakthrough hemolysis, loads and loads of new agents. But if there is a clonal regression, should we think of curative options in this disease? And with that, I'll sort of give my acknowledgements to a number of people, predominantly my two mentors at King's, but also number of people who work with us in the laboratory, funding agencies, EBMT, and three of my friends there in the EBMT who we did the RACE trial, which is the aplastic anemia trial, and the National PNH Service. I need to update this slide because some of the people have retired or moved on. And I think with that, I'll stop and happy to take questions.
Thank you, Dr. Austin. Thank you for this elegant presentation, quite elaborative. We have, it seems, a question here or two. Mike, please. Dr. Benyam.
Hello, Dr. Kulshegraj. This is Dr. Benyam Usman. I have a patient recently diagnosed with PNH. So 6 weeks ago, she's a child, actually, 14-year-old. 6 weeks ago, she was admitted under renal team with a creatinine of 800. And they did a renal biopsy. They weren't sure. The biopsy didn't show any particular features except for hemosiderin deposition. We sent for PNH screen, and the PNH screen was positive, significantly positive. RBC is about 21%, monocytes and granulocytes more than 50%. She was only treated with fluids and steroids at that time because the diagnosis wasn't clear. And she recovered, no dialysis needed. Her renal function completely normalized. The LDH, which was 3-4 times upper limit of normal, almost normalized, but running at around 400. Hemoglobin also normalized. So 6 weeks down the line, she's hemolyzing, but a low level hemolysis, and the renal function is completely normalized. My question is, I mean, should we be starting her on eculizumab now to prevent such episodes in future? Or do you think it is like a one paroxysm and we can just wait and watch this girl?
Yeah, thank you for that question, and it's a tricky one. Number one of the things you've described is it's a 6-year-old, and I think PNH is not.
Sorry, Dr. Austin, it is 14-year-old.
Oh, apologies, 14-year-old. So to answer your question directly, I think I would treat, because we've got about 4 or 5 patients who are not in a dissimilar but different age groups, where they present with acute hemolysis, i.e. like what you described as a paroxysm. And what happens is they get significant hemolysis, and a couple of them have had a needed renal replacement therapy and dialysis as well. Although the paroxysms might not be that frequent, if you wait for the next one, that could be a life-threatening one. And quite a lot of patients do that. And I never call any patient as a stable PNH patient, because there is always a risk that they will get worsening hemolysis during any episodes of trigger. I know your patients did not have any obvious trigger for the hemolysis, but some patients, even just simple things like vaccination, stress, maybe this girl sort of menstrual periods as well. Some people get it prior to the menstrual periods as well. Vaccination, these are all quite a few stressors which can induce further hemolysis as well. So preferably, I would consider this patient for anti-complement therapy, be it eculizumab or ravulizumab, because there is good data of ravulizumab now in the context of pediatric population as well. The clinical trial is just completed, so there will be data for that. And if you're allowed to use it in your country, I would consider definitely this patient for anti-complement therapy.
So I think it could have been the COVID vaccination which had triggered it off in her case. The second question I have is, would you recommend the 600 followed by 900 dose, or do you think a 600 dose might be okay for her to continue?
I think it depends upon her body weight as well, is it? So if she's a slightly larger person, definitely I would go with the standard dose, because it might not be sufficient with the 600 dose. You just need to look at the dose ranges for that age population and the weight of the patient.
One last question. Yes. Dr. Ayman is looking at me. I have a patient who was on eculizumab, responded well, young man, then breakthrough hemolysis. I increased the dose. We went up to 1500, but still hemoglobin is running below 8 with significant reticulocytosis. In this scenario, if I had pegcetacoplan, would you go to pegcetacoplan, or would you try ravulizumab, or what would you suggest?
So I think the question here is whether this is breakthrough hemolysis or extravascular hemolysis. If you're sure that this is breakthrough hemolysis, then definitely I will consider for ravulizumab. But if you think this is extravascular hemolysis, then that patient should be similar to what the patients were included in the Pegasus trial, i.e. anemic, hemoglobin less than 10.5, plus or minus transfusion dependency, despite higher doses of eculizumab. So you got two choices. One, if you think this is pharmacokinetic breakthrough hemolysis, i.e. if the LDH is going up on day 12, day 13, day 14 prior to the infusion, definitely somebody worth considering for ravulizumab before you can consider them for other agents like what you described.
Well, thank you. Dr. Abdullah.
Thank you for this excellent presentation. Sometimes you have patients who present with unusual thrombosis in unusual sites, and they don't have any other explanations, and you do the PNH testing and the clone is positive, but they don't have hemolysis. They respond to anticoagulation, and I know that the evidence is not great for using such therapy to control the PNH clone, but what have been your approach to these cases?
Thank you, Dr. Abdullah. There are a couple of important issues in that which you've raised. There are very rare group of patients who do not have hemolysis, but have a large PNH clone. So this was reported about a couple of years back in Hematologica, where we had 5 or 6 patients who just had large granulocytic clone, but did not have red cell clone. So which is why there is always this discussion. There are patients with PNH who don't need hemolysis to cause them thrombosis. So this is a very rare subgroup of patients where there is only white cell clone, granulocytes and monocyte clone, which could be sufficient because of endothelial activation and other pathophysiology that they could get a thrombosis. So there is no point in monitoring LDH in that group of patients. And if you're convinced that there is no alternate etiology, there is a large PNH clone, then anti-complement therapy is something which needs to be considered. The second part of the question is sometimes we do PNH clone in patients with unprovoked thrombosis and find a PNH clone of 0.01 or 0.1%. Those cases, I don't think so PNH is the reason those patients get a thrombosis. There should be an alternate etiology for those unprovoked thrombosis.
So last question by Dr. Ihab.
Thank you for the nice presentation. I can see that there are many novel agents coming in the pipeline. Do you think there will be a paradigm shift in terms of the treatment for PNH? What do you think the future holds for us?
Yeah, so definitely there will be, because I think we're all excited that there are so many drugs which are in all of them are now in phase 2, phase 3 trials. So I think your estimate of 5 years is definitely what we are looking at, where patients would have a choice between an IV 2 weekly, IV 8 weekly, subcutaneous daily, subcutaneous 4 weekly, or oral tablets twice daily. So I think that's what we are waiting for. And I think 5 years would be sufficient to have some data from phase 3 clinical trials to draw up to say, yes, there would be newer agents in the horizon which patients would be able to access for it. The one thing I don't believe in it, although we are doing trials of add-on therapies, but I think add-on therapies does not work from an economic perspective as well, because you would want to treat and control a patient with one treatment rather than 2 treatments.
Well, thank you very much, Dr. Austin, for the very interesting presentation, very interesting discussion. And we'll end this session. And this was the last session of the day. So this is going to be an interesting night tonight. I think Dr. Ihab has announced the evening symposia and also the dinner for tonight at 8 o'clock. So with this, we conclude the day and have a good rest of the day. Thank you.
Later at 8 o'clock at the hall 1. Hall 1, 8 o'clock in the evening.